Pag in-unmute.
Greetings, everyone. Thanks for your patience. We're now live on YouTube. This is Gisela.
Nasasabihin na kami, ano dito, Christine.
Ano lulutuin nyo?
Everyone kindly mute. Thank you. Greetings, everyone. Thanks for your patience. We are now live on YouTube. Gisela Concepcion of PAASE here. On behalf of my co-host, Dr. Manuel Dairit, and the whole of PAASE, I welcome you to this PAASE Fireside chat on ways forward in the midst of ivermectin for COVID in the Philippines. Special greetings to our PAASE members, to the members of the National Academy of Science and Technology, especially our national scientists, our medical doctors in the audience, also representatives from government, the private sector, media, and the general public. Special thanks to our speakers who have taken valuable time to speak today courageously, sharing with us their knowledge of the scientific evidence on ivermectin and their analysis and interpretation of the data. As you have noted on the poster, we have one key speaker. She will be introduced by Dr. Dairit, and she will speak for 45 minutes. The reactors will be introduced by me afterwards. The purpose of this chat or forum is to provide an objective explanation of the topic and to seek clarity and find ways forward amidst the pros and cons of ivermectin for COVID in the Philippines. PAASE is an organization of over 450 PhD level scientists and engineers and medical doctors of Philippine descent based in the Philippines, the USA, and other countries. Our tagline is Agham at Kaalaman para sa Bayan, science and knowledge for our country. Last week, we held the first fireside chat on ivermectin. Based on the discussions on first ways forward from that chat, we posted a survey on ivermectin with medical doctors as respondents. You may view the response of over 500 MDs so far on the PAASE website. Notably, a large majority of MDs would like to know more about ivermectin. Thus, the sequel chat today. Note the deadline for the survey is on April 12. We hope more MDs will join the survey. To respond to the MDs' needs, we are posting these chats on our website and also providing references on ivermectin, such as the link to the Living CPG documents and to Nobel-laureate Omura's group's review of ivermectin. Prior to the chats on ivermectin, PAASE hosted a fireside chat on vacuna or vaccines several weeks ago. Like all PAASE fireside chats, you can view the recording of vacuna from our website. We would like to make this clear at this point. While PAASE as an organization stands firm on vacuna or vaccines and deplores or laments the slow rollout of vaccines in our country, PAASE does not take a position pro or con ivermectin. PAASE is a large heterogeneous group. There are members who are pro ivermectin and there are those who are con ivermectin. Individual PAASE members or groups of them are free to express their views on ivermectin. After our first speaker and then our actors have spoken, we will open the floor to a Q&A or discussion. Kindly type your questions on the chat box. Keep your questions simple and not complex, as we request our speakers to keep their answers within 2 to 3 minutes. This is in the interest of equal time and opportunity for everyone. And if you wish to ask a question, kindly raise your hand and wait to be recognized, and then identify yourself and also keep your question simple and not complex. Okay. So at this point, I would like to introduce our co-host, my co-host, Dr. Manuel Malalet Dairip, who is a PAASE member, former Dean of the School of Medicine and Public Health of the Ateneo de Manila University, former Secretary of Health of the Republic of the Philippines, and former Director of the World Health Organization Group on Technical Services and Human Resources, Technical Services of the World Health Organization in Geneva, Switzerland. So may I now turn over the floor to Dr. Dairip. Thank you.
Thank you very much, Giselle. And good afternoon to everyone, and good morning to Tess, who is over in the UK. I have the very pleasant task of introducing Tess Lawrie, who I haven't met personally, but I've seen in a number of YouTube discourses on ivermectin. I will go through her CV very briefly. Actually, Tess comes from South Africa, and she actually started her career as a obstetrician and gynecologist, training in Johannesburg in South Africa. And she also was associated with one of the prominent universities in South Africa as a clinical research fellow. And that was the University of Witwatersrand in Johannesburg. So from this university, Witwatersrand, she actually then moved to the University of Stellenbosch, which is another prominent university in South Africa, also was a clinical research fellow, and continue on working in obstetrics and gynecology. But eventually, she moved over to the UK in Bath, in a town called Bath in the United Kingdom, where she still continued to work in obstetrics and gynecology, but eventually moved into the area of research. And so she became a research scientist. And from 2011 up to the present, she became a consultant at the Cochrane Gynecological Cancer Group. If you've heard of the Cochrane collaboration, which is a group that actually does a lot of studies, many of them meta-analysis on interventions. Tess was a member of that group, particularly focused on obstetrics and gynecology. And then eventually in 2013, she became the director of the Evidence-Based Medicine Consultancy Limited, which is a private group that actually does a lot of this research work. So, as I understand it, Tess got interested in ivermectin when she saw Dr. Pierre Kory in the Senate of the US, and eventually got into ivermectin of her own accord without any prodding from anyone. And eventually, because of her studies, were able to share her findings really in the UK and on a global level. And now she's here with us to speak to us on ivermectin. So what we've actually asked Tess to do is really to help us understand the evidence on ivermectin. We know that there are various groups that do the analysis. WHO is only one of them. There are other groups in the UK, including the Liverpool Study Group, and so on and so forth. And the methodology around analyzing all of the studies on ivermectin is really quite intricate. And therefore, I think part of the challenge of Tess this afternoon is to be able to explain to laymen, and you might say neophyte statisticians, how she's looked at the evidence and what her findings are. And after Tess speaks to us, in 45 minutes, we're going to have 5 reactors who are going to give their own take on Tess's analysis and give their own views on this issue. So without much ado, may I invite Dr. Tess Lawrie to take the floor. Tess, you have the floor. Thank you.
Thank you for that wonderful introduction. Very comprehensive. It's such an honor to be here today, and I appreciate having that you've all taken the time to come and look at the evidence on ivermectin. So without further ado, I'm going to share a screen, a set of slides with you. And I'm going to be discussing and showing you the evidence on ivermectin to treat and prevent COVID. I'm going to stick with the main outcomes that of death and serious adverse events, because these are the things that will guide decision-making on ivermectin's use. This is a news article from yesterday in the Philippines, Philstar. I was quite dismayed on reading this because it seems to present the same old misinformation that we've become so accustomed to in the story of ivermectin. For example, the emphasis on it being a veterinary drug, when in fact it's been used in humans since the early 80s, late 70s, very successfully, and it's won the Nobel Prize for its incredible use in humanity, in healthcare and humanities. So it just seems very strange to refer to it as a veterinary drug when we all know that it's saved many lives and also been unbelievably useful in combating parasitic diseases around the world in humans. And then also, I hope to show you that it does not pose serious negative effects, and why this is something that is promoted, this idea promoted by the health authorities, is an enigma to me. As Manuel told you, I first became involved in the story in late December when I saw Dr. Pierre Kory's presentation to the US State Senate. And I read his review, which I thought was very comprehensive, and it had evidence on mechanisms of action, it had evidence on country real world evidence, it had observational studies, it had randomized controlled trials. And at that stage, Pierre Corey was an expert in using ivermectin too, so it also had his expert opinion that ivermectin needed to be looked at for treatment and prevention of COVID. So I had a week off between Christmas and New Year, and I buried myself in the data and did a rapid review of the randomized controlled trials and also of the better quality observational controlled trials. This is a forest plot of the randomized controlled trials. And I think most of you in the audience are familiar with forest plots, but I'll just briefly outline that the studies are listed on the left here. And these are the data on ivermectin with events in the one column and the total sample size of the studies on the right. And that's the same data for the control group. And then we get a risk ratio plotted on this axis here. And we have a summary estimate at the bottom, which is an average in this case of the effect estimates across these studies. So of these 6 randomized controlled trials, and this is the analysis of deaths, our primary outcome, the most important outcome when we're talking about COVID in a pandemic. This analysis showed an 83% reduction in deaths with a confidence interval of 45% to 94%. This figure here, the I-squared was 0, which indicates that the findings of these studies are consistent. They're all saying the same thing. And so because there was no inconsistency, the estimate was precise. I downgraded this evidence -1, and I'll go into the grading later, but I downgraded this -1 for study design limitations. And I reported this as moderate certainty evidence. And this was corroborated by the subsequent analysis. I did RCTs only, and then I looked at RCTs and the good observational controlled trials. And there were 3 of those. And I came up with that gave a similar estimate of, which suggested a 70% reduction in deaths with a confidence interval of 45% to 87%. So it's not usual to put observational controlled trials and randomized controlled trials in the same forest plot, same meta-analysis. Usually if you have adequate randomized controlled trials, you just focus on those when you're doing a Cochrane review. However, I took a pandemic license, which I think is a reasonable thing to do in a pandemic. I've never been in a pandemic before, but it seemed reasonable to look at the better quality studies and the better quality observational studies, as well as the randomized data together, and see if it made any difference. And in fact, the observational data presented a more conservative, perhaps real world estimate of 70%, which was lower than the original 83% when we just looked at the randomized controlled trials. So in early January, I tried to communicate this I put my report on my website. I had tried to get the BMJ to engage with me on how it could be published quickly, but I was unable to get any undertaking from them. It was just a standard reply saying I needed to go through the usual mechanism. And I was really wanting to save lives at this stage. I felt the evidence was important and needed to be communicated to health authorities immediately. So I emailed my report to a colleague at WHO and asked her to forward it on to the COVID team. I also I emailed the health department in the UK. But after a few days, I felt the burden of death on my shoulders because there were no responses from any of these authorities. And so you may be aware that I put a video appeal on YouTube to the Prime Minister of the UK and asked if he could contact me. I didn't get a response from him, but I got an overwhelming response from international health professionals and the public saying, please could I help their regulatory bodies and governments understand the evidence? And so what I did was I put together an author team to do a comprehensive Cochrane style review, a Cochrane review. And there were 3 very experienced systematic reviewers. We had a health economist on the team, we had 2 specialist clinicians and a consumer representative. We followed strict Cochrane methodology. We used randomized controlled trials only. We assessed the risk of bias of every trial, and we used the grade approach to assess the certainty of the evidence. Where we could not get clarity on certain methodological aspects of a study, we emailed the authors, and most authors were very quick to respond. We submitted a protocol of this review to Cochrane on the 14th of January. At the same time, Dr. Andrew Hill from Liverpool had been commissioned to do a review with WHO and Unitaid, and this became available as a preprint on the ResearchGate website on the 18th of January. In Dr. Hill's review, he included 6 randomized controlled trials with 1,255 participants for the death outcome. And the only difference between his RCTs and ours was that he had, in my initial report, was that he had the study from Turkey, and it's just skipped my mind now which one he doesn't have of ours. But in any event, very similar findings showing a 75% reduction in deaths and a confidence interval of 48% to 88%. Very little mild heterogeneity or inconsistency. So, but he did not grade his evidence. What he did do is he concluded that many studies included were not peer-reviewed and meta-analyses are prone to confounding issues, which is unusual thing to say, and that ivermectin should be validated in larger, appropriately controlled randomized trials before the results are sufficient for review by regulatory authorities. So the understanding was that WHO were waiting for more data on ivermectin to emerge. Just something to be said about preprint servers and unpublished data. In the 2015 health emergency with Ebola, there was a statement put out by WHO in collaboration with journals to say that during public health emergencies, every researcher that engages in the generation of information related to a public health emergency has a fundamental moral obligation to share preliminary results. The onus is on the researcher to disseminate information through pre-publication mechanisms, hence the preprint servers, and journals should not hinder the sharing of data that could help mitigate the impact of such emergencies. I'd further like to add that when one does a systematic review, in particular when one emails the authors to request additional information, one is, for all intents and purposes, doing a peer review of the paper. And when you do a Cochrane-style systematic review, you have 2 authors evaluating each paper. So there is no need to dart, once a assessment of the risk of bias has been done on a paper, even if it is on a preprint server, there's no need to dart and further undermine the findings. So after the Hill review, our review became ready on the 8th of February, and we submitted it for publication. It is currently on a preprint server, so it went to peer review. It passed the peer review process, but the journal that we submitted it to decided not to publish. So what it shows in this updated meta-analysis is that there were 13 trials that contributed data to the analysis of deaths. These are randomized controlled trials. They had almost 2,000 participants in the trials altogether. And there were 25 deaths that occurred out of nearly 1,000 in the ivermectin arm and 82 deaths that occurred in 900 in the control arm. There's quite a lot of heterogeneity across these studies because they were conducted in slightly different populations, some more severely sick than others, and they used different doses of ivermectin. Some of them compared ivermectin to an active treatment like hydroxychloroquine. This is not a weakness of the analysis, this is a strength, because we still get an effect estimate strongly in favor of ivermectin, showing a 68% reduction in deaths and a confidence interval of 28 to 86%. We graded this as low to moderate certainty using very strict criteria. Low certainty evidence, well, actually, perhaps I do go into how the grading works a little bit later. So let's continue and I shall explain it later. We then updated our meta-analysis on the 31st of March when the WHO statement against ivermectin came out. And there were two new studies that contributed data on deaths. There was Lopez Medina, which is the JAMA study you might have heard about, that was fairly controversial. And there's Gonzalez. When we added these data, we end up with a total number of participants in these studies of nearly 2,500. 30 deaths out of 1,300 in the ivermectin arm, 89 deaths out of 1,138 in the control arm, and a risk reduction of 62%, with a confidence interval of 27% to 81%. So we're just seeing basically a consistent effect as time progresses of ivermectin on the risk of death. With this analysis, the I-squared has become lower. And this is one of the criteria that one evaluates when you are grading the certainty of evidence. So according to the standard operating procedure that I usually employ doing the work that I do for WHO on their guidelines, this evidence now becomes moderate certainty, which means that there's probably a reduction in deaths of 62%. To confirm this, because of all the controversy around ivermectin and the grading and so on, because you'll see later on WHO has a very different grading for the outcome death, I sent the analysis to colleagues who do a similar thing to me. They do this external consulting for WHO. I de-identified the analysis. I took ivermectin out and I just said, could you grade this according to WHO standard operating procedures as you usually do, and let me know. They looked at, and obviously I sent them the risk of bias tables that we had prepared. And they returned a verdict of moderate certainty too. So I feel quite certain that according to the standard operating procedure of WHO that we usually employ for our guidelines, that this evidence is moderate certainty. Now, how does the grade approach actually work? Well, when you're dealing with randomized controlled trial evidence, you start with high certainty. And then you downgrade -1 or -2 for study design limitations, inconsistency, imprecision, indirectness, and publication bias. So -1 would suggest that any of those criteria, there are serious limitations, and -2 would be very serious limitations. So you would go from high certainty, and then if there were serious If there's serious imprecision, for example, it would become low certainty. I'm sorry, if there was very serious imprecision, it would become low certainty. Or if it was just serious design limitations, it would become moderate certainty. So what the different certainties mean: high certainty means that further research is unlikely to change our confidence in the estimate of effect. Moderate certainty means that further research may change the estimate of effect. Low certainty means that further research is likely to change the estimate of effect. And very low certainty means we're very uncertain about the estimate. It could be in favor or against. WHO recommends not to use ivermectin for COVID except in a clinical trial. These are the latest recommendations on ivermectin from the 31st of March. In their certainty of evidence, they say that evidence was rated as very low certainty, primarily because of very serious imprecision for most outcomes. The aggregate data had wide confidence intervals and or very few events. This is the analysis in the WHO guideline. It's the only forest plot that they show. And so it was all we've really got to work with. And they've only included 5 trials in this analysis. And they've subgrouped them according to high risk of bias and low risk of bias. This I find quite unusual, because usually you'll do a sensitivity analysis to exclude studies at high risk of bias, but you wouldn't subgroup them unless you've pre-specified that's what you're going to do in your protocol. So I haven't seen the protocol for this review, but perhaps it is there. These 2 studies we assessed as being high risk of bias, but they're in the low risk of bias category. So this is something further that we would like to follow up and get clarification from WHO. And they have really few events, only 9 out of 511 in the ivermectin group and 22 in the standard of care group out of 404. So they've got less than 1,000 people in this analysis. They still get a 72% reduction in deaths with a confidence interval of 25 to 83%. Clearly in favor of ivermectin. But they've used a very restricted analysis, because in their earlier analysis that Andrew Hill did, they had these other studies, and they're not in the new analysis. So not only are they not just looking at randomized controlled trials, but they seem to have decided to restrict the analysis even further. And I think this is because they've only evaluated ivermectin in the context of a pre-existing network meta-analysis design. So in fact, they're not looking at all the evidence on ivermectin. They've just perhaps had to select the studies that fit in with their network meta-analysis design, where they are trying to compare lots of different medicines. And it's not quite clear when they've got standard of care here, that standard of care is what the standard of care is, because at least one of these studies has an active control arm. So again, we really need clarification on this, especially when you look at their summary on the outcome for death, where they have an odds ratio of 0.19. I'm just going to flip back to the other slide. You can see here they use risk ratios, but in their summary table, and there's 5 studies here, but in their summary table, they use odds ratios and 7 studies. Now, unfortunately, we don't have a meta-analysis forest plot for the data that they're presenting in the summary, but this is based on 7 studies in 1,419 patients. And there's a very, very tight confidence interval. It's 0.09 to 0.36. So it's a very precise estimate. It shows a reduction in deaths of 81% and a confidence interval of 64% to 91%. So it would be very good to be able to see this analysis. And their description of the absolute effects are showing that in the standard care group, 70 out of 1,000 people would die. And in the ivermectin care group, 14 out of 1,000 people would die. So it's a risk difference of 46 fewer deaths per 1,000. But they've graded this very low certainty. So what did they downgrade for? Well, they've downgraded for very serious imprecision. And we've already seen that the estimate is very precise. So if they've downgraded for very serious imprecision, that's -2. And if they've erroneously downgraded -2 for very serious imprecision, then one is left with moderate certainty evidence, because you would go from very low certainty to low to moderate. So in actual fact, if there's no imprecision here, then this is moderate certainty evidence, which agrees with our findings, even though it's far fewer data. And in my mind, this demonstrates the consistency of the effect of ivermectin across numerous meta-analyses, and it's been evident from the start of, since I started looking at this in December, and obviously to others it's much more evident because they've known about ivermectin a lot longer than me. I just want to compare this to the grading of serious adverse events, because, sorry, I think I might have missed a slide here. No, okay. They've graded, so they've also graded this as, well, they've downgraded this due to, they've said to very serious imprecision. Now, unfortunately, we don't have a forest plot. There's no forest plot for serious adverse events in the guideline itself, but what we can see here is that they've based the data on 584 patients in 3 studies, and they have a confidence interval of 0.77 to 12. So this is a very imprecise estimate, and rightly so, they've downgraded it twice for very serious imprecision. But they've interpreted it incorrectly, because what an imprecise estimate like that means is that ivermectin may make little or no difference to serious adverse events, and yet they've reported it as ivermectin may increase the risk of serious adverse events. So this is rather peculiar, and from these data you can see there were very few adverse events anyway, so we're probably looking at less than 5 adverse events or something like that, 5 or 7. And so it seems like this would be more appropriate to be a very low certainty estimate. They haven't commented on study design limitations in their grading, but this is certainly the wrong interpretation of these data. From these data, there's no difference in serious adverse events between these 2 groups. And this is our updated serious adverse events meta-analysis from the 31st. So these are the data that are actually available on serious adverse events. But in the WHO analysis, there are only 3 trials that are included. So in actual fact, you can see we've got nearly 1,447 participants, 10 RCTs reporting serious adverse events. And they show 7 adverse events in ivermectin, 2 in the control group. There's no clear difference and very few data. So then there may be little or no difference. And we don't know, we've graded this as low certainty evidence, hence the may, so there may be little or no difference, but in any event, the events are rare or uncommon serious adverse events. And I won't go into more detail, but you could see if you look back on the slide and you want to pause it, you'll see that we've subgrouped these according to the doses. And this is a pre-specified analysis in our protocol. We've subgrouped according to single dose or multi-dose. And you can see that the adverse events, most of the adverse events occurred in those receiving ivermectin plus other drugs. Just a bit more on the safety side of things. More than 3.5 billion doses of ivermectin have been given. And yet when you look at the Vigico Access Pharmacovigilance Database, which is a database set up by WHO and the Uppsala University in Sweden, you'll see that it's a very, very safe medicine. Since 1992, there are 16 deaths recorded against ivermectin and 5,156 adverse events as of yesterday. And if you look at the other medicines that are in use, remdesivir since last year has had 470 deaths registered and 5,775 adverse events. And if you look at the vaccines, well, we're already looking at 3,000 deaths in just 3 months and adverse events of 442,485 since yesterday. So there's a double standard being applied here. Why the one is safe and the other and ivermectin is considered unsafe just doesn't make any sense at all. The other thing there's just been a failure of the authorities to do is to look at the real world data. And there's a mountain of it. I'm just going to use Peru as an example, but Peru approved ivermectin for use in COVID in May last year. What they did was the ivermectin was distributed to every person over 60 and those with comorbidities by the army and other departments. And they noted the excess deaths dropped by 75% at 45 or more days after the operation started. What this looked like on the graphs, that these are prepared by Juan Chemi Quintero, is that you can see big drop off in deaths from COVID, even though the community was still mobile. So it wasn't something that was caused or associated with strict lockdowns. You can see the community's out and about, but the COVID incidence and the death rates are down. Now, this is not an isolated graph. There are many like this, and you can see them in our bird proceedings document. And there are also publications by Juan Chemi Quintero, which go into this in more detail. So we have country case studies that show real world evidence that show that ivermectin is making a difference to deaths and COVID infections around the world. There's also the fact that there are African countries where ivermectin is these community directed strategies for worm control. And the countries that are on these programs with mass administration of ivermectin have much lower COVID death rates than the countries that don't. So in terms of the factors one needs to take into account when you're thinking whether or not to use a medicine, well, ivermectin probably reduces death substantially with few serious adverse events. It probably reduces COVID-19 infection. Now, I haven't shown these data, but I will show them a little bit towards the end. Emergency use authorization has been acceptable for vaccines and other novel treatments, so why not ivermectin? Because ivermectin has more safety data. And we also know that it's safe in the elderly because it's used to treat elderly folk with scabies in nursing homes. And it's also safe in immunocompromised people. We know this because there's a WHO document on scabies showing that it's acceptable for use in immunocompromised people. In actual fact, in the current WHO guideline on COVID, ivermectin for COVID, they say that ivermectin can be used in immunocompromised people, with COVID to prevent worm infections. And then there's the question of long COVID, for which we know there are many, many sufferers around the world, and there's no option. So one thinks, well, what is there to lose by trying out an older, safe medicine that's probably very effective against acute COVID? About 5 to 10% of people who get COVID end up being hospitalized. And 25% of hospitalizations require ICU. We know that WHO has ivermectin on its essential medicines list and that it's very, very cheap. It's also generic, which means that countries can manufacture it themselves. There's no refrigeration needed, no administration costs because it can be mailed to people or made available over the counter at pharmacies, and it's effective for prevention and treatment. So it's very low cost and very feasible. Such so that many countries around the world and health medical bodies are making the decision themselves to use ivermectin in spite of the health authorities constantly insisting that there's no evidence on ivermectin and that ivermectin is potentially harmful. For example, the All India Institute of Medical Sciences, a very prestigious body, has now recommended that ivermectin be given daily for 3 to 5 days in mild disease. Just a word on ivermectin for prevention. This was our forest plot from the review that we published on the preprint server at the end of February, early March. And there were 3 studies, only 738 people, and but a clear indication, a clear benefit in favor of ivermectin. It showed an 86% reduction in COVID-19 infection, and with a very narrow confidence interval. Across these studies, the infection rate was 5% with ivermectin compared with around 30% with the control group. Again, this is a very narrow focus on a few RCTs when there is much more evidence on ivermectin for prevention out there. But the Cochrane protocol that we did, we said we would look at RCTs, and certainly the WHO is only looking at randomized controlled trials when they're looking at this evidence. Of note is that Prof. Schumann, who conducted his study in Egypt, stopped his study early because of the clear benefit in favor of ivermectin. So one just gets a sense that we are looking at such small data. We've sort of narrowed our focus. It's almost as if there's this huge body of evidence out there, but the authorities are insisting on looking at a very narrow focus and saying, oh, well, there's not enough evidence, we want more trials, when there's really plenty of evidence and nothing to lose with giving ivermectin a shot. This is what our data show on prevention. If there's 296 infections per 1,000 amongst those at risk, we're talking healthcare workers or family members of people with COVID, their risk of infection is you'd end up with 296 infections per 1,000 using the data across our analysis. And the corresponding risk with ivermectin is 252 fewer infections per 1,000. So for every 4 people you treat, you prevent 1 COVID infection. We graded this as low certainty evidence because of many study design limitations. And what this means is that ivermectin may have a significant effect on reducing COVID-19 infection. However, when you look at the observational data, you realize that this is a much more certain than what the data from RCTs show. I just want to spend a moment talking about equity, because rollout of vaccines has been slow, as you mentioned in the beginning, Gisela. And there are certain countries where it's going to be slower than others. It's a big investment for many countries. And there are also countries who are just waiting for further safety data, especially with AstraZeneca being recalled. There are limited safety data with the vaccines. So ivermectin can effectively reach traditionally hard to reach and vulnerable populations, such as the elderly, healthcare workers, or frontline workers. Those, also just thinking in terms of equity, many people don't like needles. And such people might be excluded from vaccination programs. So it's good to have an alternative. It just, it makes absolute sense. And then also in terms of long COVID, there's lots of equity considerations related to long COVID. It's really terrible that people are suffering for so long, and ivermectin may be able to help them. We used our evidence and put together an evidence to decision framework for a group of international stakeholders. And on the 20th of March, we presented the evidence to them and asked them to make judgments on each criteria. At the end of the meeting, there was the overwhelming majority voted in favor of ivermectin for both prevention and treatment. And we made a recommendation as a result of the meeting as follows. The British Ivermectin Recommendation Development Panel recommends ivermectin for the prevention and treatment of COVID-19 to reduce morbidity and mortality associated with COVID-19 infection and to prevent COVID-19 infection among those at higher risk. So my conclusion is that the use of ivermectin for prevention and treatment of SARS-CoV-2 could have an important impact on the pandemic, and we should be using it. Thank you. I'd be happy to take your questions now.
Thank you very much, Tess. But I guess before we open the floor for questions, we're going to have reactions from our reactors. But before we go there, Tess, I think there are a few maybe technical clarifications, because we have a very laymanish group also. And of course, there are many doctors here. But could we just be very clear, when you talk about the quality of the evidence, could you just define what you mean by high quality, by moderate quality, and by low quality?
Yes, so in fact,
we talk about this, okay.
Yes. So I prefer to talk in terms of certainty. Okay. Now, what one needs to realize is that the evidence underpinning other things, for example, the treatment, for example, remdesivir, the evidence underpinning that is not high certainty evidence. There's a misunderstanding. People think that they think that clinical practice is guided by high certainty evidence. So this is simply not the case. Any clinical practice guideline will make recommendations on a range of certainty and take into account the other factors. So you don't just make a recommendation on high certainty. Often there can be very low certainty evidence, but a recommendation gets made. So very low certainty evidence means you don't know whether there's a benefit or a harm. The estimate is so flimsy. Low certainty evidence, if it's in favor of an intervention, is important evidence, especially if it's a substantial reduction, as in with ivermectin. Moderate certainty evidence and low certainty evidence says that this is the estimate, but it's likely to change. So, we had a confidence interval for deaths, for example, of 68%. What it's saying is that you can't be certain that you're always going to get a 68% reduction in deaths. We are confident that that this is the estimate from this to that, and it's somewhere in there. So you're more likely so the estimate's likely to change. Whereas with moderate certainty evidence, you interpret it as it may change. So further research is going to be useful, and it will confirm our confidence in the estimate, which may change. And then high certainty evidence, well, we're pretty sure of this estimate and it's unlikely to change. Yeah, but it's not, I think people are under this impression that low certainty evidence is useless. Well, that's not the case at all.
Okay, thank you. Well, I don't want to preempt any of the reactors, so I'm going to turn over to Giselle now to introduce the reactors so that they can give their reactions. Giselle?
Thank you, Manolete. So it's my honor and pleasure to introduce our reactors, one after the other, in the interest of time. Our first reactor will speak for about 15 minutes is Jacinto Blas Jojo Mantaring, MD, Professor and Chair, Department of Clinical Epidemiology, UP College of Medicine, Clinical Professor and Practitioner, Pediatrics, Neonatology, Philippine General Hospital, and Chair, UP Research Ethics Board and DOH Single Joint Research Ethics Board. Our second reactor will be Benjamin Benji Ko, MD, Medical Practitioner, Pediatrics, Infectious Disease and Clinical Pharmacology, UST Hospital, Asian Hospital and Medical Center, Carlos Santos Medical Center, and former director of the Center for Drug Regulation and Research of the Philippine Food and Drug Administration. Our third speaker will be Vicente June Belisario, MD, Dean, College of Public Health, UP Manila, former Vice Chancellor for Research and former Executive Director, National Institute of Health, UP Manila, and former Undersecretary for Technical Services, Department of Health, Republic of the Philippines. Our fourth speaker, reactor, will be Rafael Rafi Castillo, MD, Medical Practitioner and Senior Consultant, Adult Cardiology, Manila Doctors Hospital. And he is the consultant. I have to get this right because what's on the poster is not accurate. So this is the updated one. Trustee, Council Member, International Society of Hypertension. Fifth speaker is Benigno Iggy Agbayani Jr., MD, Chair, Department of Orthopedics, Manila Doctors Hospital, Medical Practitioner, Arthroscopy and Joint Reconstruction or Arthroplasty, and President and Co-founder, Concerned Doctors and Citizens of the Philippines. And our sixth reactor is a PhD, Dr. Leodovico Vic Ilag, Chief Scientific Officer, Xerion Australia, Chief Scientific Officer, Horizon Science from 2011 to 14, and Chief Operating Officer of Patris Limited from 2007 to 2010. So at this point, may we ask Jojo to share his slides and greet our audience? Thank you.
Thank you, Giselle. I'll share my slides. I just want to verify if you can see my slides and hear me well.
Yes, Jojo.
Okay. Thank you. So again, thank you to the PAASE for this invitation. It has only been a week since I examined the literature for this talk. And since my last talk, I have been able to look at synthesized literature. And I thought that I would start this talk, but before that, let me give you my disclosures. I'm the chair of the Department of Clinical Epidemiology of the UP College of Medicine, the chair of the UP Manila Research Ethics Board and the DOH Single Joint Research Ethics Board. I'm not an infectious disease specialist. I'm not representing any interest group. I have not had experience in treating COVID, but I have no interests in any company that sells or manufactures any product related to the management of COVID. And I thought that I would start this talk exactly what Manolet had hoped. No? I first want to remind the audience, especially the non-scientists, why the need for randomized trials and what are systematic reviews and meta-analysis, and how these systematic reviews are interpreted as well as appraised. And I will go through well, just two in the interest of time. I've only been given a few minutes for this reaction. Pitfalls of a meta-analysis, because I believe that a lot of the meta-analysis that are out there have pitfalls. And finally, I would like to introduce the audience to the living systematic reviews, particularly that of Cochrane and WHO, and for that matter, the Philippine living guidelines for COVID-19. So let me just remind the audience, especially those who already listened to my talk last week, on why patients improve. No, the patients improve. Their improvement can be the effect of treatment, but there are differences in treatment, dose, duration, and co-interventions. Different people may have different host factors. They have different resistance. They have different general health, genetics, nutrition, and all of these can make a difference on why some patients may improve and others may not. No? There are also other factors like disease factors, environmental factors, socioeconomic factors, and differences in patient outcomes and manner of outcome assessment. Um, so why the need for trials? In a randomized trial, people who are eligible, so there are very strict inclusion and exclusion criteria, are randomized into two groups. One who will get the treatment and one who will not get the treatment. And these groups are followed up over a period of time for the outcome of interest. And only through randomized controlled trials will you be able to generate objective and unbiased evidence on treatment effect. The design is the gold standard for research questions on efficacy and effectiveness. And it provides the methodology that will control for factors that may influence the outcome, particularly randomization. Randomization provides an equal chance for all eligible participants to be allocated to treatment or no treatment. And this equalizes the baseline characteristics for known and unknown factors that may influence the outcome. And the treatment factors, the host factors that I had mentioned, the disease factors, environmental factors, and socioeconomic factors will all be controlled because chances are the two comparison groups will have an equality for those factors. And it has the advantage of controlling for not only for known factors, but also for unknown factors. Furthermore, the clinical trial standardizes the treatment dose and duration and standardizes the outcome and outcome assessment. So what are systematic reviews and meta-analysis? These are part of what we refer to as integrative study designs. So a review is an integrative study design. It integrates the results of two or more studies. The problem with a review is that the author may have chosen to review only the articles that he agrees with, and he may have chosen not to include the articles that he does not agree with. So there could still be bias in a review. Now, this is avoided in a systematic review. The systematic review integrates the results of all eligible studies that are retrieved from a systematic, comprehensive, and objective search. So the keywords are systematic, comprehensive, and because it's systematic and repeatable, and it's comprehensive, it becomes objective or unbiased. And if there's any study that will be excluded from a systematic review, there has to be a basis or a justification for why it had been excluded. A meta-analysis goes one step beyond a systematic review. It includes a quantitative method for integrating the results of the independent studies and synthesizing the summaries and conclusions. And what the systematic reviews have that are an advantage over randomized controlled trials is that it provides a better source of evidence. So as this pyramid will show, the weakest sources of evidence will come from editorials, perhaps, and expert opinion, case studies, case series, case reports. They're second weakest, followed by case control studies, cohort studies, and only randomized trials or systematic reviews of randomized trials will provide better evidence. So anecdotal reports are all case reports, and testimonies are also case reports, are considered case reports. No? Cohort studies are observational studies, and they don't provide the same level of evidence as that of randomized trials. And when we say systematic review, I cannot help but mention the role of the international Cochrane collaboration. This collaboration fine-tuned the methodology for the conduct of a systematic review, including the tools necessary for the analysis. No? RevMan 5.4 is the most recent tool for a meta-analysis, and it's downloadable for free. Other than that, the Cochrane collaboration maintains the Cochrane Library of Systematic Reviews and Clinical Trials. So the International Cochrane Collaboration is a non-profit and independent organization dedicated to making up-to-date, accurate information about the effects of healthcare readily available worldwide. It produces and disseminates systematic reviews of healthcare interventions. And it promotes the search for evidence in the form of clinical trials and other studies of interventions so that it can be included in the Cochrane Library. Now, I would like to introduce the audience to what we refer to as the living systematic review for COVID-19. And I will go over the results of the living systematic review for COVID-19 later during this reaction. So I'd like to show, this is a page lifted from the website, and the living systematic review for COVID-19, the COVID-19 Open Living Evidence Synthesis to Inform Decision, or COVID-NMA, is an international research initiative that's supported by WHO and Cochrane. And I'll show you the website later and include in this reaction a demonstration of how to use it. I also would like to say that there is the Philippine COVID-19 Living Recommendation. So these are experts in infectious disease and clinical epidemiology who are tasked to systematically search for evidence on healthcare interventions, particularly for the treatment of COVID-19. Included in this collaboration is the University of the Philippines, Manila, the Institute of Clinical Epidemiology of the National Institutes of Health, and the Philippine Society of Microbiology and Infectious Disease. It's supported by the Philippine Council for Health Research and Development. But before going to the results of the meta, let me first try to summarize how to interpret meta-analysis. First of all, for each individual study, the results of the study, especially if the results are dichotomous, are reported in risks. No? Relative risk is the risk of the outcome among those who are treated, which is in the numerator, compared to the risk of the outcome among those who are not treated, or the control group, which is in the denominator. So as you can see, if the numerator is less than the denominator, you will have a relative risk of less than 1, which means the intervention, whatever it was, reduced the risk of the outcome. Let's say the outcome is death. That means those who were treated had less death compared to those in the control. And therefore, the relative risk of less than 1 is considered a beneficial relative risk. If the relative risk is equal to 1, this means that whether they are treated or not, the risk of the adverse outcome is just the
Jojo, can you hear me?
am I back? I think I was disconnected.
Yeah, you're back.
Jojo,
Jojo, you're fine. Great.
Okay, thank you. Thank you so much. Sorry for that inconvenience.
but
I'll add
Jojo,
that.
repeat part of what you said because some of us had
You
missed
want
it
me to
already.
repeat? I thought people were saying that they were getting bored. So I was saying that the relative risk of less than 1 suggests that the treatment is beneficial. A relative risk equal to 1, meaning the numerator, the risk in the numerator among those treated compared to those not treated, is just the same, which means that there's no difference in the outcomes among those treated and not treated. And a relative risk that's greater than 1 is suggestive of a harmful intervention or a harmful outcome, because
Jojo,
those treated are at a higher
Please
risk
share
of getting
screen.
out.
please share screen, Jojo. Your
Oh, I'm
screen is
sorry.
not showing.
Is it showing now?
No, not
No, no.
It's still not showing. Gosh,
No.
I guess I have to stop share first.
Yes. AMG has started sharing screen. Who is this person? This is what is showing.
Is my screen showing now?
Not
No,
yet,
it's
Jojo. I don't know if it's frozen because AMG has started sharing screen.
who is AMG,
I think
please?
somebody else started sharing a screen. I'll try again. Can you see my screen now?
I think,
No.
Giselle, do you have controls over that?
Just a moment.
Yeah,
There you
it's back.
It's
Okay, it's
showing now.
back.
It's showing now.
Yeah,
thank you.
I'm sharing now.
yeah.
Okay, thank you. So I was saying that a relative risk less than 1 is beneficial, one that's more than equal to 1 is useless, and a relative risk more than 1 is harmful. And the relative risks are presented both as an estimate and an interval estimate or confidence interval. And all of these are shown in a meta-analysis. So for example, in this meta-analysis, the leftmost column identifies the paper by author and year. And it shows the event rates among those who are treated and the event rates among those who are not treated. And it shows a graph of the relative risk and the confidence interval, but it also shows the numerical values of each. Okay, and so all the treatment, all the events in the treatment are added, and all the new denominators are added, and they will come up. This will allow us to come up with a summary. Of course, it's not as simple as that because there's weighting that's done by inverse variance, but never mind that. So that's what this shows, no? And further for the interpretation, if your plots are to the left of 1, it favors treatment. If it's to the right, it favors control. Okay. In the interest of time, let me skip that. But a risk of bias table is generated in every systematic review. So it looks at random sequence generation, allocation, blinding, and you can tell from each study where the biases could be. And as long as there's a high risk of bias in any of these studies, in any of these domains, then that study has a high risk of bias. Okay, so let me just go straight to my reaction. No? There are several pitfalls in conducting and interpreting the results of a meta-analysis, but I will only discuss 2 which I feel are the most relevant to the analysis of Dr. Lawrie. Meta-analysts should only combine studies that have similar enough patients, similar enough interventions in terms of dose duration, same outcomes, and same methods. For example, studies that looked at adults should not be combined with studies among elderly. Studies that compared ivermectin with hydroxychloroquine should not be compared with studies that should not be combined with studies that compared ivermectin with placebo. Studies that look primarily at viral clearance should not be combined with studies that look primarily at mortality rate and so forth and so on. So it's comparing apples and oranges. And how do we determine whether what you're combining are apples and not oranges? We need to look at the elements of the well-phrased question. We need to look at the patient, population, or person, exposure or intervention, comparison, outcome, and even methods. And you can only combine the results of studies that are similar enough in terms of the elements of the research question. The second is garbage in, garbage out. A meta-analysis is only as good as the studies that are included in the meta-analysis. In any study that has a high risk of bias, in any of the parameters, the whole study is considered as having a high risk of bias. So if the studies that make up a meta-analysis are of poor quality, then you should expect the meta-analysis to have poor quality. And quality can be assessed using the GRADE method. GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluations. And uh, Cochrane assesses quality using several domains: the risk of bias from randomization, deviation from intended intervention, bias due to missing data, risk of bias due to outcome assessment, and risk of bias due to selection of reported results. Um, I'd like to stop share first and show you, let me see, show you a website, the website. So I'll share again. I'd like to verify if you can see this website. So this is the Philippine Society for Microbiology. So this is the Philippine COVID-19 living recommendations. But what I wanted to show you more was the COVID NMA, or the Cochrane WHO living systematic review. And it allows living evidence synthesis from pharmacologic treatments. So we can just type ivermectin. And it will show you the studies that comprise the systematic review. By the way, this is a very detailed and transparent methodology, but I don't have the time to show that. So let's look at the forest plots. And if you go to this site, you can share, you can choose the comparison. So we can choose ivermectin versus standard of care or placebo. So it removes all the other comparison groups. It does not include ivermectin versus hydroxychloroquine. You can select the outcome. So let's say mortality. Let's include even the subgroup analysis, and let's include even those with high risk of bias, and generate the forest plot. And this is what the forest plot shows. So it shows that for mild outpatients, the risk ratio is 0.33, but it crosses 1. So it can be as low as 0.01 to as high as 8 times. And what did we say about a relative risk greater than 1? There's a chance that the ivermectin causes harm as much as there is a chance that it causes benefit. For the mild population, the relative risk is 0.39 with a confidence interval of 0.11 to 1.32. Again, no, it crosses 1. And when all of these are combined, it's 0.38 with a confidence interval of 0.13 to 1.12. Again, it crosses 1. And it shows you the risk of bias in all of these studies with a legend. So it shows the risk of bias domains, bias due to randomization, deviation, missing data, etc. And it has very wide confidence intervals. So in terms of certainty of evidence, this is imprecision. Now, if you want to change the outcome to clinical improvement and create the forest plot, it becomes very precise. So in terms of clinical improvement, it certainly does not lead to clinical improvement in the ivermectin group compared to the no ivermectin group. And that's what the living systematic review says. So let me just wrap up. Just a few more slides. So I already mentioned these pitfalls. So I showed this earlier. So based on the living recommendations of Cochrane and WHO, there is no evidence to suggest, based on systematic reviews and meta-analysis, that ivermectin compared to no ivermectin or placebo is effective in reducing deaths among COVID-19 adults. There is no evidence to suggest, based on systematic reviews and meta-analysis, that ivermectin compared to no ivermectin or placebo is effective in clinical improvement. But there is still hope because there are still ongoing clinical trials, and it is likely that these results may still change once these trials are completed and incorporated into the living reviews. So this summarizes what I intended to say. I think I've gone over time. I'm sorry about the having been lost earlier. So thank you very much for your attention.
Thank you, Dr. Mantaring. Manolet,
Go on. Giselle.
Ben, or should we ask Tess to comment at this point?
I think it's probably good to comment at this point because it will keep things in comparison. Otherwise, I might forget the questions by the end. Thanks very much for your feedback, Dr. Mantaring. To address the first question about apples and oranges, I think, with all due respect, with your narrow focus on looking at placebo-controlled trials, you're missing a lot of the data. Our research question was, what is the effect of ivermectin compared with no ivermectin? And that is why we included we included studies with ivermectin compared with hydroxychloroquine. We included the study of ivermectin compared with ritonavir. Now, apparently, those treatments are ineffective. So for all intents and purposes, one is comparing ivermectin with no ivermectin, and the overall effect of ivermectin should become clear in a meta-analysis. Our meta-analysis question was, what is ivermectin compared with no ivermectin? And therefore, it would have been highly biased if we'd excluded studies that compared a different treatment. And what we did was we did our primary analysis, and then we did sensitivity analyses to exclude those studies that, so first we did sensitivity analysis to exclude studies at high risk of bias to see what the effect was on excluding those studies on our overall estimate. And it was very similar. So therefore we left those studies in. With regard to your question on garbage in, garbage out, I really take issue with that because the studies that are done by these researchers in low and middle income countries, all 21 of them, or one of the studies was done in Spain, but most of them were done in low and middle income countries in Egypt, Bangladesh, Argentina, and they are done by doctors like me, who've worked in these resource-poor settings, and they're done with the purest of intent, and that is to help patients and find out what is going on. Now, I have spoken to many of them, and a particular doctor in Bangladesh who conducted one of the studies told me that he knew really early on they were not going to be able to afford these expensive treatments. They had to use what was at their disposal. And so that was why he conducted a randomized controlled trial of ivermectin. And so, and it's for the, and now it is being used in his hospital and to great effect. So to say that these studies are garbage is really, and it really, what you're saying is that only studies that are conducted in high income countries with big budgets funded and so, are any good. As I mentioned to you, when you do a systematic review, you actually, if you do it properly, you actually contact the authors, you ask them about their methodology, and you assess the risk of bias accordingly. With regard to the outcome death, the most important aspect to look at in terms of risk of bias is how the randomization procedure was done and whether allocation was concealed. Where that wasn't clear, we contacted the authors and asked them, and if it was clear that there was no allocation concealment or that randomization was inadequate, for example, with Lopez Medina trial, the trial that everyone seems to hail as being a very high quality trial, when in actual fact it's very flawed and at high risk of bias, then you have, then you assess the risk accordingly, and you call it a high risk of bias study. And you then, when you're doing your assessment of the evidence, your grading of the evidence, you're looking at how much weight that high risk of bias study is adding to your overall evidence. So I'm quite sure that those studies are not garbage. There are some that aren't great, and we assessed, we removed them, and we saw that our evidence, our effect estimate remained the same. And then we assess the evidence according to the routine grade procedure, where if you've got a precise estimate and enough events, you certainly don't downgrade for imprecision. So I hope that answers your questions.
Thanks, Tess and Jojo. I think we're zeroing in, focusing on the critical issues, the differences in your analysis. And Manolette, I would like your comments on this before we move on to Benji.
Yeah, I think it's a very, very important point, because it has to do with the studies. And I think the point that Tess was raising, because that where you really want to have the randomized controlled study as perfect as possible. And what that means is that the study, the respondents, the intervention, and the outcomes are all in sync. But I think there are situations where they're not. And that's why you then grade the quality of the evidence. And I think what I take away from this, from Jojo's point, which I take on board, and Tess's clarification of that point, is that when Tess actually selected the studies or not. So this is my takeaway as a layperson on the selection of the studies. Did I paraphrase that correctly, Tess?
I'm sorry, you broke up a bit there. Would you mind repeating the question?
When you explained that for your research question, you were looking at
Can you hear me, Tess?
interventions
I
with
can hear you.
ivermectin. And yeah.
Sorry, I can hear you, Gisela, but I lost Manuel for a sec. So I think you said, you just were asking clarification what our research question was. So yes,
Yeah.
so we were comparing ivermectin with no ivermectin. So,
Exactly.
especially if you look at severe disease,
That was a
with severe disease, people are getting lots of different treatments. So, and doctors are doing what they feel is appropriate. So, you wouldn't not give something, doctors feel that it's unethical not to give something.
Okay, thank you.
Okay.
It's made there, Tess, and that it's very difficult to really compose a perfect RCT.
It's very difficult, and in actual fact, I think something strange is happening with the evidence on ivermectin, because there's so much of it. It's not just, if you look at these slides that my colleague presented earlier, where you've got systematic reviews at the top, and then you've got RCTs, and then you've got observational studies, and at the very bottom you've got expert opinion. When it comes to ivermectin, you have all of that evidence. You've actually got the whole pyramid. You've got evidence at every single layer that favors ivermectin. So why are we not using it? We're in a pandemic where people are dying. There's nothing to lose. It's cheap. The evidence shows it's probably very effective. We know it's very safe. It just seems like a no-brainer. And to keep sort of nitpicking and saying, oh, we have to wait for a very big randomized controlled trial funded by X, that trial's not coming, in any event, or there may be one, but, there are concerns about conflicts of interest. So I think we've got to go with the data we have from these dedicated doctor researchers and from the systematic reviews that we've done, which all suggest that ivermectin is good for treatment and prevention. And it's the best option we've got at the moment. There are other options that, there are other things that doctors are recommending, for example, vitamin D. I'm not suggesting ivermectin is the only thing we can give patients to treat illness, but certainly it's the best option we have, and there's nothing to lose by employing it.
Thanks, Tess. I think the issue here, Manolet, is a real world versus the ideal situation. So let's move on to our next reactor, Dr. Benjamin Ko, who's an infectious disease practitioner. So he's a frontliner. We'd like to hear from you now, Benji.
Can you hear Benji? Giselle? I think we lost you.
I'm contacting Dr. Ko.
Okay.
Okay. Oh, he wants to be unmuted. Binchu, can you unmute Dr. Benjamin Ko, please?
All right. Okay. Anyway, that was a very interesting conversation a while ago and presentation. And I will not touch on the regulatory point of view anymore, because we know that a compassionate special permit has already been provided by the FDA to one of the hospitals within the National Capital Region. I think the issue before was the availability of a human-grade ivermectin in the country, because there is a difference in the licensure and the availability of ivermectin in the country. And I think that has been settled already, so we will not need to go to that. From an infectious disease point of view, there is potential for the drug. However, I still have a lot of questions. Okay, so I'm not keeping my mind closed. Let's not, let me put the point that we all want to get out of this pandemic. We're all trying to look for a treatment. We're looking for treatments anywhere from direct therapy and direct benefits to patients. But I'd like to find out what the differences, basically I'd like to find out the pharmacology of ivermectin for SARS-CoV-2, because there is data in vitro. However, if you look at all the clinical trials, there is paucity of pharmacokinetic, pharmacodynamic endpoints for all of the clinical trials. So there is a mixed bag that goes with the promotion of ivermectin for prophylaxis. And then there is a group that says that, all right, it can be used also for treatment. So I'd like to see where the difference is in prophylaxis and in treatment, because for infectious disease, for antimicrobial therapy, you will need to make sure that you have a basis for prophylaxis and you have a basis also for the treatment regimens. In short, like for example, if I tell you that prophylaxis for patients who've been wading in floods for leptospirosis is given for this duration, then this is the only duration that you will have to administer it. The question is, how long do you give it in patients in a pandemic? So, and you must make sure that there is adequate pharmacokinetic and pharmacodynamic data also, PK/PD endpoints, because you need to have, if you are able to show that it is effective for a virus, then there should be a minimum inhibitory concentration for this as well, right? It's like antibiotics or antiparasitic therapy. You must meet a certain endpoint for treatment, whether it is an antiviral, whether it has purpose, or it is repurposed as an antiparasitic, an antiviral, etc. And that's very important, because if you reach subtherapeutic doses of a drug, the problem is you might end up developing drug resistance eventually, particularly at doses that have not been evaluated properly with pharmacokinetic endpoints. So that's one of the issues that I'd like most of the clinical trials, and I think the Lopez Medina study points that out also as one of their limitations, that they lack PK/PD data. And I think if you look at most of the studies, there are very, very few. I've not seen one that provides you an endpoint actually on PK/PD data. So that's very important, particularly for, and then you look at the safety data as well. No? As a clinical pharmacologist, I look at the safety data. While it is true that ivermectin has a very wide safety profile, this is based on data from antiparasitic therapies for phase 1 and 2. Because it is possible that the actual dose for treatment, in order to achieve serum concentrations adequate enough to reach certain organs in the body for the treatment of SARS-CoV-2 for either mild, moderate, or severe infections, may be much higher, or at 10 times the recommended dose. We don't know. We really don't know, because like I said, no, you're looking at two endpoints, prophylaxis and therapeutic. It's being recommended also as prophylaxis. So if I give it as prophylaxis, how sure am I that I am able to adequately achieve serum therapeutic levels that is able to exhibit inhibition for SARS-CoV-2? So these are things that we should at least, these are endpoints that will actually give you more data and will assure you how useful ivermectin is in the general population. That's just my comment. But you know, I'm not pro, I'm not against it. I'd like to compare all the data that there is, that is out there. Who knows? It might be something that is a possibility in the future as we collect more data.
Thanks
Can I
for
respond
that.
to that? Yeah, so I'll beg your pardon. Shall I respond?
Yes, please,
Yes,
Tess.
yes.
Well, thanks very much, Wendy. I think those points you raised do seem to keep coming up in the news, so it's good to be able to address them. Firstly, with regard to the mechanism of action, there was the one study from Cayley in March last year that came out showing that ivermectin cleared SARS-CoV-2 within 48 hours in vitro. and that it had potential for use in COVID. And they were using very high doses, and this has given everyone the impression that ivermectin can only be given at very high doses, and it's unlikely to be effective clinically. Fortunately, several other studies have been done now highlighting how ivermectin actually works, and it has several mechanisms of action, and there are at least 5 papers aside from the Cayley study which show different mechanisms of action, and it's quite clear that it has very potent antiviral properties. It's also an anti-inflammatory, which is why it works early on in the viral course of disease and also later. The earlier it's employed, the better. So we have to look at the clinical data, and the clinical data show us it's effective too. We don't need to look at, we've got all these scientists working on its mechanism of action, and I'm sure it's of great fascination to them because they are finding there's evidence that shows that it impacts the replication of the virus, it supports the cell's immune system by preventing the viral proteins getting into the nucleus, amongst other things. In terms of dosing, all the studies that have been done have used reasonable doses, the same doses that are used for scabies and worms and so on. So there's no reason to worry that you have to give very high doses. In any event, Merck did a study in 2002, it's Guzzo, 2002 is the study ID, and it was a randomized trial, and they used 10 times the dose of ivermectin, and even at 10 times the dose, the study concluded that ivermectin was very safe. I'm not suggesting you use 10 times the dose. We know that it works at normal doses, the same doses you would use for scabies and worms. The other thing is, although people are using different doses around the world, it has a very wide therapeutic index. So it doesn't seem to matter whether you use it for 0.2 milligrams per kilo per day for 3 days or 5 days for treatment courses. It seems to work, and there are many different protocols being used in many different countries at the moment. In terms of prevention, it is very interesting that it seems to work. There are also different regimens. For example, Pierre Corey uses a fortnightly regimen for himself and people who, and in his protocol. And it's the same, it's 0.2 milligrams per kilo every 2 weeks. But I've spoken to physicians in India, and they use it monthly. So it does make, and to great effect amongst hospital workers. So it does make you wonder, what a fascinating medicine that it seems to have this long, even though its half-life in blood is 3 days or 2 or 3 days, it seems to have a long half-life in tissue. And I believe preliminary studies from Wagstaff and Cayley, which is are showing that it can last up to 12 days, or its half-life is 12 days in lung tissue, which might explain why it is a good prophylactic against COVID. So there is much to learn about this very fascinating medicine, but it doesn't need to be a barrier to us using it. I hope that's answered your question.
Yeah, can I ask? No, I just want to make the comment that I think what is lacking, and I have no objections actually on how you want to use it. What I'm saying is that if we keep looking at clinical data, we should try to do a study that has a pharmacologic correlate in the end, in order to make sense out of the clinical data that you are recommending. Because at the end of the day, like for example, we know for a fact that the half-life of ivermectin is on the average is 18 hours. And if we give it as prophylaxis, do we have enough ivermectin in the system in order to exhibit its supposedly prophylactic effect. Because that's one endpoint. Because if you're able to address that, then that's very good. So we've had one issue down. That's at least addressing that issue on the dosing for prophylaxis and how we should administer it, in spite of the fact that we say that there is a wide margin of safety and we can go from dose A to dose B, or from 10 to as much as 100 milligrams, if that need be. There are no other pharmacologic data or phase 2, even phase 2 studies, no? That we don't even need to go to phase 1 because it's just safety. On phase 2 studies on the appropriate dose to be given for patients who are being treated for SARS-CoV-2 or being administered as prophylaxis. Because once you have that, that already is a gold standard. And I think that's where we have paucity of data in, looking for a gold standard for treatment.
I think we just want something that works. But may I make a suggestion? Why don't you in Philippines do a prophylactic study where you look at a 12 milligram dose for prophylaxis every 2 weeks and compare it to a 12 milligram dose every month in your healthcare workers, and just see if that helps, because I'm sure it will take a while for the vaccines to get rolled out. So this is something you could do while you're waiting for the vaccines. And that would answer your question.
Could
Okay,
you repeat that, Tess? You wobbled. Could you repeat that?
Oh, I said, why don't you do a study in a randomized controlled trial in the Philippines amongst your healthcare workers, where you give the one group ivermectin every 2 weeks and the other group ivermectin every month, and because it's going to take a while before the vaccines are rolled out. So, you know, that you could do this in the meantime, and nobody's going to lose anything by doing that, and you would provide an answer to this very important question.
In the meantime, Manolete, my suggestion
Okay,
was
Manolete.
still the point that we still don't have pharmacologic endpoints. Because I think by achieving pharmacologic endpoints, we will be solving half the mystery behind how effective and how good ivermectin actually is. And my particular endpoint is, like, for example, if you're taking a drug for prophylaxis, and if you draw it at 3 days, 5 days, and you're seeing 0 levels of ivermectin in the blood, the question now goes back to you, and you know, it asks that question of, is it ivermectin that's working or is it not?
I think what you're missing is that ivermectin can go into the tissues as well. It might not be in the blood.
But that includes volume of distribution. Because if you look at volume of distribution, that will explain to you on how much ivermectin goes into tissues and whether they stay there. And you can actually do studies on volume of distribution by doing biopharmaceutic studies.
It is interesting. The pharmacokinetic studies are interesting. But at the end of the day, we're talking about people, and clinical effects of a medicine of what's important at the moment. There are many scientists working on in vitro studies with ivermectin, but we also fortunately have lots of clinical evidence, real world evidence, that ivermectin works and should be employed. So I think what you need to remember is we're in a pandemic. There are people dying, there are infection rates increasing. We don't need to know every single thing about this medicine. We are learning more and more all the time, and there are many scientists working on it. There are many publications on the mechanism of action. There's many on inflammatory markers. We can see that it reduces inflammatory markers, and this is one of its great benefits in late stage of disease. So, I just think, really, look at the science, look at the data. You can see that this is a useful drug. It's very cheap, it's very safe. Let's just start using it, at least for treatment.
Thanks, Tess. And Benji, in the interest of time, we move on. the first chat on ivermectin, our speaker, Vic Ilag, talked about the molecular mechanisms of action of ivermectin. And also, maybe our audience, Dr. Benji Ko, can look at the BIRD, British Ivermectin site, okay, development panel recommendation for information on pharmacodynamics and pharmacokinetics. We have to move on to our next reactor. Dr. June Belisario is actually a worm and parasite expert, and he's actually published work on ivermectin in for treatment of Ascaris and other parasites. So, June?
Thank you very much, Giselle. And hello, Manulet. Thank you, Lawrie, Tess Lawrie, for the comprehensive presentation. I listened in to Dr. Benji Ko and, of course, my colleague in UP, Dr. Mantaring. And, of course, it's a continuing learning experience for all. And as such, I'd like to complement the discussion this afternoon, reactions from a medical parasitology and public health perspective. Of course, ivermectin is not a new drug, but the current use, approved use in so many parts of the world, WHO endorsed, it's a broad spectrum antiparasitic agent. And of course, over time, the use of ivermectin for parasites of medical importance in humans has expanded. Note that in the 80s, it was just an antifilarial drug, anti-filariasis. And in 2017, noticing that it's a broad spectrum antihelmintic, then it covers more helminths and helminth infections. In 2019, believe it or not, evidence was shown that it is a very good ectoparasiticide. And for the lay folks in the audience, ectoparasiticide in Tagalog will be our galis and kuto, which are actually among the neglected tropical diseases. I think the lesson of this slide shows that new indications have been described and recommended as part of standard of care, both clinically and in public health over time, based on peer-reviewed scientific evidence. But note, there is an importance of consensus. Now, I like what's going on today. There's continuing debate, sharing of evidence, discussion. Let there be debate, but at the end of the day, we talk about consensus because the consensus brings us towards a unified response and action. So, such is the expanded indications of onchocerciasis. And another, believe it or not, is that there's new evidence that shows it prevents malaria infection. I will mention that just briefly. Established, ivermectin as a very effective anti-parasite drug. And in fact, ivermectin is being used now as part of combination therapy, as part of combination preventive chemotherapy, where anti-parasite drugs are given on a mass scale. Now, imagine that, Giselle and Manolet, people ages 2 to 65 receiving the drugs, even without the benefit of diagnostic tests. But I'll talk about the dosages in a short while. The dosages are low dose, and it's only administered, even if it's a combination or single drug ivermectin, it's only administered just once a year. And it actually implies on what Dr. Benji Ko has been talking about, some pharmacological considerations in the use of ivermectin. Okay, so single and now it's combination. And note that the combination therapy was not even adopted immediately as part of standard of care or as part of control, in fact, elimination of the filarial worms. But of course, there's a vast difference in that here we're talking about the neglected tropical parasitic diseases, which are actually not public health emergencies such as what we have now in COVID. So there's a bit of a difference. And as such, because of the safety profile, efficacy and effectiveness in community settings, mass drug administration without benefit of diagnostic tests directed against selected parasitic neglected tropical diseases. In fact, the originator, MSD, has a Mectisan donation program. This is the brand name of Ivermectin, donated through WHO. WHO quality assured drugs donated to many, many countries, especially in Africa. Philippines is not a recipient because we do not have onchocerciasis in this part of the world. And it's co-administered by another drug donated via a donation program from GlaxoSmithKline. Note also that ivermectin comes in tablet form. I'm a bit disturbed, Giselle and Manolete, because I saw, for instance, purchase of ivermectin in the Philippines online, and these are capsule form. So you wonder where they're coming from. I mentioned as part of my first slides that ivermectin is now an accepted ectoparasiticide, alternative to permethrin for scabies, and given in low doses but 1 week apart. Ivermectin, as part of peer-reviewed scientific evidence, consensus from the experts, including expert groups advising WHO, is now part of the standard of care for scabies and pediculosis. A bit of evidence now that ivermectin may be helping reduce malaria transmission. If you recall, medical doctors share parasitology, infective stage of malaria parasites will be sporozoites. And thus, with ivermectin ingested by mosquitoes, it shortens the lifespan of the mosquitoes, according to some literature. And as such, there is reduction of transmission of sporozoites. And thus, it might play a role in malaria prevention and control, given in low doses again, 1 month apart. Ivermectin, however, is not yet part of the standard for malaria control and prevention, as there is a need for further studies. And again, there is a lack of enough peer-reviewed material and not enough basis for consensus that will allow it now to become part of practice guidelines. So that's the process that a product has to follow. Note that the dosages as anti-parasitic agent are quite low. For COVID prophylaxis, the literature talks about more than the usual dose. And in fact, I saw in one of the slides of Tess Lawrie, the recommendation in India is something like you give it for 3 to 5 days. And there is a lack of experience along those lines. But I suppose that the Indian regulatory authorities may have had some basis about that. I am not a COVID expert, and as such, I wish not to comment on that further. There is limited information that ivermectin may be well tolerated with high doses by healthy adult subjects, but this has not been tested at even higher doses. Again, lack of information along those lines. So in general, adverse drug reactions related to ivermectin generally low, and safety profile is established, but the safety profile is along the lines of it being used as an anti-parasitic agent. Where dose is low, where the duration of administration is limited, and as such, it is in that kind of a context that these statements are being made. And therefore, even with some low incidence of adverse reactions, the benefits for as antiparasite far outweigh the risks, which is of course ideal for selection of products for medical and public health use. And just like other medical products, there are instances, rare as they may be, about severe or serious adverse effects. And among them, ivermectin toxicity recorded in the literature, in this case where ivermectin was used for scabies. And this has happened only in the last year or so, where a patient develops coma, meaning getting into a comatose state, neurologic symptoms 6 hours after intake. And this has been related to genetically confirmed nonsense mutation in some gene, resulting in failure of the blood-brain barrier. So things like this happen. And as such, ivermectin use should be supervised by a medical practitioner. And intake of ivermectin directed against COVID may need to be also medically advised if and when ivermectin has been now recommended for such use. There are also reports of unusual adverse reactions. Now, in this case, toxic epidermal necrolysis. And again, this is with the new use of ivermectin against scabies. So there's a huge possibility that things like this might happen with more and more use of ivermectin for COVID-19, no? with higher doses. The last example I have is drug reaction with eosinophilia and systemic symptoms. And again, this is the use of ivermectin for the relatively new use against scabies. Ivermectin COVID-19, I think we have heard from Tess Lawrie, we've heard from Dr. Jojo and Dr. Benji. The current position, of course, is that there are limits to the clinical trials made available. We do want to hear more about the debates of the experts. And of course, we do look forward to learning from the debates, and hopefully there is a consensus that is arrived at towards the end of those debates, so that we're guided in terms of a unified response and action. I will end, Giselle and Manolete, by having my closing points. Now, first, enough scientific evidence that ivermectin is generally a safe and effective antiparasitic drug, expanded indications in the last decade. There's been extensive use on a mass scale, and such is the vast experience of of ivermectin, but specifically for antiparasite use. Adverse reactions are mostly mild and transient, but may be severe and life-threatening. Thus, the role of the medical practitioner in overseeing, prescribing ivermectin, overseeing treatment with ivermectin for specific conditions other than anti-parasite use. The new indications, such as for COVID-19, will need to be based on scientific evidence on safety and efficacy. I think we have quite a bit of that. Peer-reviewed, there's quite a bit of that. Endorsed by expert groups, I think we need more of this. We need consensus. We need to hear the consensus. We'd like to listen into the debates, and we wish to be able to learn how they arrive at the consensus, so that the consensus becomes a convincing move forward. Regulatory authorities, a crucial role, but in consultation with expert groups, please. And such is the process that will need to be followed. Now, we're of course concerned when things are fast-tracked, not following a process. Now, we wish to be able to see a process that actually guarantees first and foremost safety, because we're dealing with people, human lives. Last but not least, health communications from the public health side of things. We will need to help all understand the process so that people will act accordingly. What has happened in the Philippines is that expert 1 talks about this, expert 2 disagrees, expert 3 talks about this, and expert 4 disagrees. Pseudo expert 1 talks about this, pseudo expert 2 talks about this. We need consensus. Expert groups, we need to hear from WHO, of course, as the global health authority. We'd like to hear from regulatory authorities from the United States, United Kingdom, Australia, Japan. Of course, our Philippine FDA has made a recent stand on compassionate use. We'd like to hear about what the other FDA authorities in the other countries have to say. Effective health communication so that everybody concerned, especially front people who are listening to the news, people who are opening websites and buying online stuff here and there, guided accordingly. I'd like to end there. Giselle, Manolete, thank you very much, everyone, for your kind attention.
Thank you, Dr. Belizario, June. And I think what you raised is important. We are moving forward towards convergence. Is that right, Manolete? And this is PAASE's little share of contributing to health communication. And actually, we are making a survey or doing a poll of how many medical doctors are attending this fireside chat. Okay, so I hope there are many of them here in Zoom and also in YouTube. May I ask Tess if you have comments on June's
Yes.
presentation?
Thanks very much. I really enjoyed that, and it was good to see how useful ivermectin's been against parasitic diseases. and also to see the side effects that you've picked up since it's been used against scabies. I'd like to just share a couple of slides again quickly, if that's okay. Let me just. And sorry. There we go. Can you see that slide? Are you seeing?
Not yet. Just a white screen.
Oh, just a white screen. Oh dear.
There it is. Something's appearing. Okay, I see it, Tess.
Okay, so this is quite an interesting slide because it shows the effect of ivermectin versus permethrin for scabies, and this is a slide that's in the Cochrane review on ivermectin for scabies. It was published in 2018, and this forms the basis of the WHO's inclusion of ivermectin in the essential medicines list for scabies. And you can see that the inclusion of ivermectin for scabies was based on low certainty evidence from 6 randomized controlled trials that in fact show that permethrin may be better than ivermectin. There's only 600 people in the studies. The effect estimate is in favor of permethrin, but they're all kind of saying the same thing. However, WHO took other factors into consideration, and that is they already knew that many countries were using ivermectin and for scabies, and it seemed to be useful and helpful. They noted that there were only 11 adverse events per 1 million treatments, and also that it was a very cheap option. So, in terms of those pictures that we saw earlier about the terrible side effects that may occur, we know that, in fact, they're very rare. And if we then, let me just see if I can find, I beg your pardon. I was hoping to find the slide. Well, I won't look for it now. I'll just exit the screen. But just to, if we just go back to, if you can recall that table that I showed you with from the pharmacovigilance database, where it shows that there's been 16 deaths attributed to ivermectin since 1992, which is less than 1 death per year. And for example, with the COVID vaccines, we've had 3,000 deaths on the VigiAccess database in the last 3 months, which if you put that over a year will be 10,000 or something, and also 400,000 adverse events. There's a real double standard in terms of how we're scrutinizing the data on safety for ivermectin, whereas the safety data on the novel treatments is just being ignored. So we're looking at that table. I certainly know which I'd prefer to get, just from a safety point of view. And the other thing, just to talk about a couple of keywords, the consensus that was mentioned by my colleague. There is consensus amongst experts around the world. And this is shown by our bird meeting, because there were, Pierre Corey was there, Hector Carvalho was there, Alan Andrita was there. There are experts using ivermectin and finding it to be very helpful for their patients. And their consensus is that ivermectin should be employed against COVID. In terms of the word fast tracking, ivermectin certainly hasn't been fast tracked. It's been put on the slow track because the authorities have known about ivermectin's usefulness since the middle of last year, since Peru first started using it. So ivermectin is on the slow track. And I think this is because pharmaceutical industries are waiting to develop their own pills. Well, we've seen that in the press, certainly there's been press about various companies producing their own pill for early COVID, so from which they could make a lot of money from. Whereas ivermectin is cheap, it's available now, and really, what are we waiting for? We need to just see the big picture of what's going on here, and ivermectin is up against a huge COVID pharmaceutics industry of hundreds of billions of dollars. And, goodness knows why the authorities are not recommending it and looking at the data, but we really need doctors to look at the data and it's common sense. It's just common sense.
Thank you, Tess. Tess, thank you. We'll move on to our next reactor because we have 3 more, and we're now running on 2.5 hours. Of course, we can stay on for another 1.5 hours. There are many questions from the chat box and in YouTube, but we'll listen to our next reactor, Rafi Castillo. Dr. Castillo, are you there?
Hi, yes, Giselle. Can you hear me? Hello?
Yes. Yes, go ahead, please.
Yeah, am I coming in clear? Okay,
Yes.
Thank you, Giselle, Manolete, and PAASE for this very kind invitation to be part of this, this conversation or this chat. Thank you, Dr. Tess Lawrie. I think, yes, your talk was very informative, and it synthesized all the available data on ivermectin and, of course, both sides. More or less, we now understand where the critics and the advocates are coming from. Thank you also to the other members of the panel. I think the beauty of forums, or whatever you call this, conversation or chats like this, is that we get to realize the blind sides that we have, which we didn't even realize at the start that we had. As Dr. Lawrie emphasized, it's difficult to understand sometimes the double standard which some experts, and including our international agencies, sometimes show in appreciating or misappreciating actually data on different interventions and treatments, and sometimes for different indications, as the case of ivermectin in scabies and ivermectin in COVID. So I just like to amplify 2 points. I'd like to build up on on that point raised by Dr. Lawrie on the blind sides that we have because of certain biases. So first, cause of blind side, as we said, is the biases that the biases that come into play in the conduct of systematic reviews and meta-analysis, and in the interpretation plus application. More important, I guess, is the application of the findings in the systematic reviews and meta-analysis. I think it's no one can deny it. I'm sure all of us in the panel and most of the people in the audience have done systematic reviews and meta-analysis and got them published. But I think we cannot deny it. Well, some of us may deny it, but bias always comes into play. Despite our best efforts to eliminate the bias, both externally and internally, it is still a big factor that we have to reckon with. It comes in many forms. I'm sure everyone knows that very well: selection bias, confounding bias, reporting bias. So even in the assessment or grading of the bias, there is also a bias. Yeah, it's because when we come in to a project, when we conduct a study, we have our own biases ourselves, our own personal biases. Again, it may not be conscious realization that we have biases, but somehow our biases are subconsciously influencing the way we will conduct the study in the ways which I mentioned. And so this can very well explain the incongruity, the incongruity in the findings and the recommendations which the authors of the systematic reviews and meta-analysis make. And I think one very good example of that is in the WHO McMaster's meta-analysis. There seems to be a dichotomy, an incongruity, which is difficult to understand and explain between their findings and their recommendations and their final conclusion, the recommendations we make. So that is something that we will always have to consider. So we should not take the recommendations of even supposedly expert societies and expert organizations and international agencies hook, line, and sinker. Because again, there is that big question about the biases, and we should be discerning enough to be able to see through these biases. I've been monitoring the studies. I would say I'm a late converter to ivermectin. I've been monitoring the study since last year when the Australian group first published their study. And it was only in late January that I finally came to the conclusion, it's like, you're making ice. It's not hard enough, but it's good enough to stand on. Like say a frozen lake, it's not that hard yet, but it's something that you can stand on. So you don't have to wait for the ice to really get thickened before you start using interventions or treatment like ivermectin. It's just too bad that I got sold on ivermectin. I got convinced on ivermectin around 2 weeks after I got infected with COVID. As some of you might have heard about it. I'm a COVID survivor. So incidentally, I think now you understand my passion in COVID. I'm just a humble cardiologist. I'm not an expert in infectious disease. I'm just a mere internist and cardiologist. But I've seen more than 100 COVID patients. I've treated, not really seen, but I've treated remotely by Viber and virtual apps. More than 100 patients in the last 4 to 5 weeks. Of course, I've read a lot about it since last year. So I don't know if one of the pseudo experts that June was alluding to, maybe a pseudo expert, but I do my assignments very well. And with all due respect to our experts, I don't think anyone can claim to be an expert in COVID. COVID is an evolving science. It's a tricky virus. And the science is evolving. That's why I guess the guidelines are termed living guidelines, because it keeps on evolving. My only regret and misgiving is that we call it living, and yet our expert drafters, the ones drafting the guidelines, have no actual experience on interventions like ivermectin. There's a hesitation to use it. A living guideline is not based on publications alone. Particularly in times like this, during a pandemic, when treatment is urgent and we cannot offer anything, a viable option that can give our serious COVID patients who cannot be accommodated in the emergency rooms anymore a fighting chance to survive, then we must be open to try treatments which can at least offer them a chance. A treatment which, in the words of Benji, at least there's a potential. He sees some potential of this treatment. In the words of June, it's a safe treatment. It's given even by non-doctors to from 2 years of age to 65 years of age without any evaluation, no diagnostic exams. And it's given in populations. In fact, in Africa, it's being distributed by illiterates, illiterates volunteers in the community. The instructions are given very simple, and they're the ones in charge of distributing it to their constituents, the population. And no harm has been shown. Of the close to 4 billion doses that have been shown, so probably more than 3 billion actual recipients, as pointed out by Dr. Lawrie, only around 18 to 20 deaths have been directly attributed. So that's something like 1 in 200 million. We don't even have enough population, to come up with one death. Our population is just 1/10. Well, that's just kidding. But what we're saying, we shouldn't be worried about safety aspect. And that's the thing when we consider a treatment during a crisis, a pandemic like this, what is the potential for harm and what is the potential for benefit? I think, the data are I really see, admittedly, I have a problem trying to understand our naysayers and our staunch critics. Like I said, when I got convinced about it in late January, the reviews then would say the reduction in mortality is 83%. Well, I think it cannot be denied that definitely it's not. Most of the data are low to moderate quality data. There are biases involved in the study. But, even if you discount it by 50%, because there's bias, 50%. From 83% discounted by 50%, that's still more than 40% reduction in mortality, better than many of the interventions, much more expensive, that we're currently using to treat our COVID patients. So again, there's that big potential for benefit. We can save lives which have no option at the moment. Because they could not be accommodated for treatment, even in the ERs. They call us in the middle of the night, doctor, what do we do? We've gone to 3 hospitals. They're full. We cannot be accommodated in the ER. So now we're in the 4th hospital, and we're told to wait in the parking lot. We're now 2 hours in the parking lot. 3 hours ago, the oxygen level was 95%. Now it's down to 85%. What do we do? So what do we offer that patient? So that is why I think we should be open to interventions like this. Again, talking about biases, I'm sure we can appreciate the bias between very affluent and industrialized countries and low-income countries. The rich countries, they snub ivermectin. They're not very interested in ivermectin. Probably they say we can afford even the very expensive medicine. So why bother with cheap, low-tech products like ivermectin? Whereas the low income countries, they're the ones who are more interested in treatments like ivermectin. Even here, now that our FDA has already allowed the compassionate usage pathway, on an institutional basis for ivermectin, I talked to 2 big medical centers, and they said, well, we'll just wait for the FDA to really give their final approval. But there are 2 government hospitals, despite the advisory of the Department of Health, they're very willing, because their patients cannot afford. Their patients cannot afford expensive medicine. So at least, am I okay? Something, I think there might be a technical problem. Okay. Manolette?
There's some
Hello,
static.
Manolette, Giselle? Is it okay? I hear some noise. Okay, thank you. So, these 2 government hospitals, I won't just mention them, they call us up and they're saying, we're very much interested because we can't offer anything to our poor patients. That's probably, I'm sure they can, they say the patients can afford for 100 pesos for a full course of the drug. But again, it's not available, but we'd like to apply for compassionate use special permits so that probably the government can help us access this product and make it available to our company, in our hospital. So again, that's again the bias. Again, the bias. What else? Where can the bias be? It's in. They say, yeah, okay. We're making ivermectin available, but it's only for as a compassionate use pathway, you know, because it's approved for other indications, but not COVID. I see again some incongruity and some dichotomy there. No one makes an issue about vitamin C and vitamin D. We use it at mega doses, 20 to 30 times more than the recommended daily allowance of these vitamins. Vitamin C, the RDA is less than 300 milligrams. Vitamin D, it's less than 1,000 IU, but we use it 10 times more, much bigger, because we're trying to invoke its immune system modulating effect. It's as a potential for COVID. So we're repurposing it. We're using it off-label for COVID. We're not using it as vitamin C, vitamin D for bone metabolism, vitamin C, you know, also for the beneficial effects of vitamin C. We're not using it for that. We're using it as a treatment for COVID, but no one makes a big issue about that. So again, why the dichotomy? If we want to, okay, so let's make ivermectin available as for scabies, as was it June or Benji who pointed very effective for scabies? So let's make it available for scabies, for ascariasis. It's listed in our formularies as an essential drug list. Essential drug list. So when we say that something is essential, that means it's absolutely necessary. It's extremely important. And when we say it's absolutely necessary, our government, having listed it as an essential drug, is obligated to make sure that that drug is readily available. Okay, readily available. So why not make it readily available and allow our doctors to use it for its established indications, but at the same time give them the prerogative, the pathway, some elbow room to also use it as they deem appropriate for an off-label indication like COVID, for so long as they are responsible for administering the drugs for indications that are not the approved indications, and of course for so long as the patients also approve of it. Now, I said there are two causes for our blind side. First is a bias. The second cause for the blind side that we don't even realize we have is what I'd like to call as pragmatism blind side. You know, pragmatism blind side. I believe that that evidence-based medicine and all these beautiful publications, researches, and clinical trials that we read about, they're only half meaningful when they get published. They only become fully meaningful if we're really able to apply it to our patients and see that our patients are benefiting because of the results of this finding. So, and I think that's the beauty. You know, when we apply pragmatism, combining it with evidence-based medicine, because we can really harness the full potential, the full benefit from these researches. And you get that maximum benefit when you actually apply it in your own set of patients. It's okay if some people call you pseudo expert or not. You know, you apply it in your own set of patients in real life setting. And I challenge our experts who are drafting the guidelines. You should do that. Apply it in your patients and come up with your own firsthand experience on the drug, not hand-me-down recommendations from the WHO or the NIH or whoever eminent. So, you know, what is best is if you can have your own experience, if you get your hands wet, or you get your hands dirty, however you'd like to picture it in an analogy. Get your hands wet and see for yourself if the drug works. And if it does, then okay, so let's all do clinical trials. Let's come up with clinical trials. Let's try to contribute to the science of COVID and the use of ivermectin in COVID. Again, the important thing is that there is no significant signal for harm. I think that's the most important thing. If we're willing to risk our patients despite all the known harms of vaccine and other drugs, then why can we not take this small risk? okay, with a potential for immense benefit on the patient. While speaking about pragmatism, I think that is one thing which we may also add to your tagline, Battleborn in PAASE, Agham at Kalusugan, Science and Knowledge. That will become more complete if there is a pragmatic application of science and knowledge to the betterment of society. So that may be a third another battle cry or tagline that you may consider making. Again, speaking about guidelines, I think we should also consider the actual clinical experience of people, of doctors who have used them in their patients. We have doctors who have used them to hundreds of their patients. Some even say they have used it in thousands, more than 1,000 patients. So I think it would also be good to consider this, when we draft our guidelines. So I know it's not something that can put a lot of weight, but it's something that we should also consider. Not only if we want to make our guidelines really living and not just a dynamic, but simply based on literatures and recommendations. So I think, some people have also I can feel their sincere intentions, very well-meaning intentions. They have cautioned me and they have advised me to tone down my comments, be less passionate, and just let it to the young ones. Of course, I accidentally sparked all this controversy with my commentaries in my column in the newspaper. I didn't mean to, but it got out of control. For that, I apologize. But I think the good thing about it is that it's now being publicly discussed, openly debated on. And I think the public gets a better picture about the issues, the pros and cons, so that they can make more intelligent decisions. So what friends and even non-friends have been cautioning me, and they said, I may not realize it, but I'm actually encouraging the doctors to break the law. I completely disagree. We're not asking the doctors to break the law. In fact, we're asking them to uphold the supreme law of the land, which is, how do they say, salus populi est suprema lex. The health and welfare of the people are the supreme law. Salus populi est suprema lex. That is the supreme law on which most constitutions are ensconced on. And all the statutes, all the laws drafted by Congress, all the administrative orders, all the ordinances should bow to that law. It should defer to that law. So we're not breaking any law. We are in fact upholding the law. So I'm an example, an analogy which I frequently give is the ambulance driver. Because they remind me that let's just wait for the green light from the FDA, the go signal or the green light from the FDA and the other regulatory authorities. Yeah. I tell them that's fine. I'm a law-abiding citizen. If I'm just driving to the mall, I don't beat red lights. When it's red, I stop and I wait for it to turn green, no matter how long it takes. But you don't tell that. You don't tell that to the ambulance.
Rafi, yes. Well, we'll have a little more time to discuss this later.
Okay.
Clinical trial.
Okay. Yeah.
So much.
It's okay. So thank you.
Thanks,
Okay,
Rafi. We want to ask for your response. We'll move on to the next, to Dr. Iggy Agbayani, but I think the issue, Manolet, of bias or disclosure is very important. So Giorgio Mantaring had a disclosure of no conflict of interest, and I understand Tess is now an independent consultant. She has quit commissioned work. Okay, so I think the question of bias is, experts. Who are the experts of the leading CPG? Okay, or the experts who advise our government? I think that's a valid question. So anyway, let's move on to Iggy Agbayani. Dr. Iggy, please.
Hello. Hello.
Okay, AJ, you're okay. Yeah, you can start.
Hi. Good evening, everyone. Good evening to our guests. We're very honored. I'm very honored because it was you who convinced me to really believe in ivermectin when I watched your YouTube with Dr. Campbell, and I think that was a beautiful day to think about it. And I began reading even more and practically spent about 3 to 4 hours a day just reading on ivermectin. And yes, you can call me a pseudo expert, but at least I read. There are pseudo experts that do not read. So if I may, I'd like to share my slides. Okay. Oh, sorry. So the title of our presentation is based on what the PAASE group has advised me, finding a way forward amidst the pros and cons of ivermectin for COVID-19. I actually have a simple motto. I trust no one, and sometimes I don't even trust myself. And that's the reason I always check everyone. I always see if they can be trusted. And you sometimes better see an author if they get interviewed. So one of the things I really wanted to do was see Dr. Tess Lawrie, and I hope I'm a bit responsible for trying to get her here, because I did try to make ivermectin popular based on your meta-analysis. So I don't have enough knowledge, or not at all. That is usually the problem when you say you do not recommend the use. A lot of doctors, when they ask, "Can I use this ivermectin?" they will say, "I don't recommend it use." And there are a couple of reasons they say that. One, they don't have enough knowledge of it, or nothing is available. Okay, my personal criteria or bias will not allow me to see the truth. Sometimes there's a problem. A person may be affected by drug companies. They may have said something before in front of their patients or their friends that I don't believe in ivermectin. And some will say experiments are flawed to make any conclusion at all. So are these really flawed studies? I think there are no perfect studies. As Dr. Tess Lawrie has mentioned, most of them are stymied by the lack of budget. This comes from places where they could not afford those expensive drugs coming from big pharma. So they are helpless and have to use things that have been repurposed. And one of them was hydroxychloroquine, and now we have ivermectin. I think there's also a problem when they say it's flawed. They're cherry picking what they want to highlight and simply not show the beauty of other studies and hide. And Tess Lawrie again mentioned one of those studies that they say is gold standard, which is the Lopez Medina paper, which I have read many times, and I really understand that it is flawed, and there have been some comments about it of some changes at the middle of the test between the placebo and the trial group. So, and the fact that in Colombia, a lot of people are already using it. And the third one is that the people that the sample size that they use are the sample people that difference. Why was it chosen as one of those gold standard studies to be reviewed by the WHO and others? So this made me think, is there a criteria for a criteria? And I came across this study. Can there be a criteria for selecting research criteria? A hermeneutical analysis of an inescapable dilemma. I decided not to read it because it was giving me a headache, but it suggested that it's both illogical and pointless to attempt to predetermine a definitive set of criteria against which all qualitative research should be judged. So I dug deep. What should determine then what can be used in an emergency health situation like in the Philippines? Tess Lawrie, I'd like to tell you that the Philippines is one of the highest rates and cases right now in Asia. It is well known that Asia has relatively no numbers, but the Philippines now is the highest. We are the worst affected. Our GDP dropped by 15 points, and that's a big change. We're down to what we were in 1946. We still haven't opened our schools. Our hospitals in the National Capital Region are full. So it's really, we are panicking, and we have no options to use for prophylaxis or treatment. And if you haven't heard, the Philippines is one of those that are not given enough vaccines. Sorry about that. So we are in dire straits, so to speak, situation. We should look at what the patient thinks. First of all, patient, while he's still aware and alive, the doctor, based on his perception and criteria or guideline he used, he should be able to decide between him and the patient. But there's a third factor, the government, who can promote or disallow or threaten patients and doctors, which we are having now. So news, compassionate use granted in the hospital setting in the National Capital Region, that's in Manila area, the Philippines. However, we look at this as a very small success. And why is that? All patients who test positive for COVID-19, only 4% or less will need hospitalization. So that is the only time you can get compassionate use. 4% of those who get COVID-19. And this is based on recent Department of Health data. So 96% will be managed at home and will still not have access to ivermectin, because that is how you're going to give ivermectin through hospital compassionate use. And those homes will have living people who will not have been tested but are very at risk of getting sick, and they will need something as well. So as we know, ivermectin is the most effective for prophylaxis, and the data shows that ivermectin can be used against COVID-19 based on 12 studies, 3 of which are randomized controlled trials showing an average of 89% protection. And these are prophylactic studies. And it can also be used for early treatment. So before, when they get sick and they are about to go to the hospital, you have 11 randomized controlled trials out of 18 studies. Ivermectin is about 80% effective. So what our country needs right now is a drug emergency use authorization. This is a slightly step down from emergency use authorization given to the vaccines. So it's allowed under COVID-19. So it's a peculiar thing. It opened doors for all Filipinos to get access to ivermectin. And ivermectin is one of those drugs that even the government doesn't have to pay for because it does cost very cheap. And I know many good civic groups are willing to help our poorer countrymen to spend for 20 to 35 pesos per capsule, and the majority of which will be used for prophylaxis. So I came across this. If you want to get a drug emergency use authorization, I found out based on the FDA Circular 2020-012, and this was made in April 2020. I don't think it's been updated. You will see that in the guidelines, the eligibility criteria, it shall be locally manufactured or imported and distributed to the management of COVID-19 patients during the pandemic following the PSMID interim guidelines. So I noticed that very much, and this is why. Why choose a non-government entity? PSMID is a good society. It has one of the best experts as the NIH. It has the HTAC. It has the Disease Prevention and Control Bureau. HTAC, actually, Dr. Mantaring, our colleague from the tropic, June Belisario, is from the NIH. So also, we can create a team of identified experts or specialists, or experts both in public health, epidemiology, and biostatistics, and not just infectious disease. That is what we need for this kind of a problem. So again, why choose a non-government entity to be the one who will determine what drug will be used? So I think there's a conflict of interest, as mentioned, and I need full disclosure. As you know, government entities are subject to more stringent checks. The Philippine Society for Microbiology Infection, or PSMID, is the country's leading professional association of specialists in infectious diseases and microbiology. I do not take that away from them. I have friends there. Okay, but do they receive sponsorships from potentially competing drug manufacturers to ivermectin, like Merck or vaccine makers? I think this should be asked because they are not, as I repeat, they are not government entities. So why not instead get the individuals from PSMID and make them the consultants of our Department of Health, and let them claim conflict or no conflict of interest. So all I ask for ivermectin is give us an even playing field. The opponents are well funded. They control the platforms. I've been banned from Facebook for 30 days. All of my friends who even mention the word ivermectin will get banned. The news media, I think they're putting up these news coming from the FDA without much coverage for us. But lately, I think we're lucky. So again, the referees are not subject to the conflict of interest or required declaration of full disclosure. And I believe the biggest judges who finally make the recommendations, the WHO in Switzerland. I think Dr. Tess Lawrie made a very good presentation. She analyzed exactly what's wrong, why they're interpreting the same data that she saw, and they're apparently changing the way it's being interpreted. As you know, the WHO in March 31 didn't even make a study of prophylaxis. So I think this is a very important point because prophylaxis or prevention of disease will be the battleground for these big pharma and a poor patent-free drug called ivermectin. So in the end, it's the patient and me who will have to decide. I will not be cowed by the government telling them that they will arrest me if I prescribe it. I will not be cowed because it's in the end, it's the patient and me. So thank you for listening. I'm Dr. Iggy Agbayani of the Concerned Doctors and Citizens of the Philippines.
Thank you very much, Iggy. Well, you gave quite an interesting recommendation there in terms of what recommendation should we follow and the role of government there. But anyway, let's go to our last speaker, and I'll take over from Giselle for a while. Can I then ask Vicky Ilag to take the floor? Vic, you have the floor. Vic, we can't hear you.
Oh yeah, can you hear me now?
Yeah, now, yeah.
Oh yeah, sorry. Yeah, so this is a bit of a different take. This is more from the biological perspective, especially from the context of its implication in the rise of the variants, as well as whether to treat early or not. Do you see it? Yeah, here. So you could start with a virus, and we know that this virus enters the cell within 10 minutes, could multiply within 12 hours to produce about a burst size about 1,000 virions, so that within 48 hours, you'll probably produce already 1 billion particles, assuming only 10% could reinfect the neighboring cell. If you reduce that to 1%, you have about 10 million. So from 10 million to about 1 billion virions within a couple of days. And that's pretty much supported by this publication preprint here. And that's only from one virus particle which infects a particular person. Now, this is one thing to consider. So it is known that it has a mutation rate of 1 nucleotide every 1 million nucleotides replicated. So the size of COVID-19 or SARS-CoV-2 virus is about 30,000 nucleotides. So for every 34th genome or virus produced is a variant. So if you look at having like 1 billion virion particles within 2 days or 3 days, you have about 30 million variants. So it's no surprise that this virus is continuously multiplying. Not only that, it's actually creating variants. So the situation right now is actually not surprising. And the main reason is the current mitigation factors which we are using, such as social distancing, masking, quarantining, doesn't do anything to stop the replication of the virus. You could put double mask or triple mask, the virus will still continue to replicate. So it's no surprise then, with that amount of mutations, that the rise of the variants will eventually happen. So the call of action then is the importance to, and if you look at all pandemics, even you go back to the bubonic plague, it only stopped when they were able to identify that the transmission of disease is because of fleas. So then they have to cut that, and then that were able to control it. The same thing with dengue virus, we know it's a mosquito. But right now, nothing is being done. That's why there's an important need for to be able to stop the virions or the virus from replicating. Now, with the debate that we're doing right now, the virus is continuously replicating, and there are people bringing the issue that we should wait. I think the issue of waiting is a bit of a dangerous game to play. The key right now, essentially, is to be able to inhibit the replication of the virus, and that's where I think people have to understand. We know that the vaccine, this is not a anti-vaccine statement, but something for consideration, that we know that the vaccine is gonna come, but it's gonna be delayed. And as pointed out by the speakers, waiting, I think, is a dangerous game under this situation. Yep. Are you okay? Yep, I think that's it. Could you hear me?
Vic, you're okay. Please go on.
Yep. Yeah, no, that pretty much wraps it.
Okay. Are you finished?
Yep.
Okay. So thank you, Vic. You know, we've gone 3 hours already, and I think people are probably tired. But can I ask Tess to react to any of the points that were raised by our last 3 speakers?
Thanks very much. Yeah, well, it's horrifying to hear that, there's so many people dying in the Philippines and with COVID at the moment, and that the rates are going up, particularly because many of these deaths are unnecessary.
May I say something?
Yes.
Hi, Tess.
Hi.
We've been showing you that some of our doctors are very strict with their randomized control trials and their criteria that we should have perfect study. Did you know that in the Philippines, there's one thing very different from other countries in the way we manage COVID-19? We have this. It's called a face shield. And it doesn't have a single randomized control study, but it's mandatory. It has no safety profile. I have patients who trip and fall. So I'm wondering why my colleagues are very strict when it comes to ivermectin, but have nothing to say when it comes to face shields.
Well, there are many interventions that have been associated with the pandemic that are not subject to randomized controlled trials. And it's not just in the Philippines. So, what I think, just having listened to everybody, I think we need to stop calling this gift to humanity primarily a veterinary medicine. It's very useful in veterinary medicine, but there are few drugs more widely used in human beings. So let's start calling it what it is. It's a very useful humanitarian medicine.
Okay, thank you.
Secondly,
go on, Tess.
I won't be long. I think we need to show some gratitude to the doctors who've done these studies in other countries. They have no conflicts of interest. There's no profit to be made. They've done it for the goodness of humanity, and I don't know how they managed to fit it in along with their clinical commitments. But thank you to them. I think if we can start using ivermectin. In fact, there are many countries around the world using ivermectin and are testimony to the fact that it's safe, because We know that safe in COVID, because if it wasn't safe in COVID, we would see those data on the pharmacovigilance database going up. Because we know that ivermectin has been used against COVID for months, I mean, almost as much as a year in some countries. So we know that it's safe for COVID. If it wasn't safe for COVID, those figures would be going up on the pharmacovigilance database. So safety is not an issue. So, lastly, I would hope that we may be able to show WHO that we don't need a 28 billion accelerated tool program for COVID for novel treatments, because we have effective treatments, and further investment of such a large size in new treatments for COVID is not necessary. Thanks.
Thank you, Tess. Well, as a moderator, can I just set the ground rules going forward? I think we'll probably have to end at around 7:30. I think we've abused Tess's time too much already. So during the course of these next 20 minutes, we can post questions on the chat box, or I can call them, and I see two people have raised their hands. So or several. Can I ask?
Chat is disabled. We cannot send our chat.
Yeah, the chat is disabled, so we can't chat at all.
Oh, I see. Okay. Can I ask Johan to first ask his question? And then Giorgio Castañeda. So Johan, you have the floor. And then Giorgio Castañeda.
Okay, thank you very much. My question...
I'd like to ask a question too.
Yes, and then we'll go Ernie Pernia. Okay. And keep your questions, please, crisp and short. Thank you.
Yeah, I was also researching about the vaccines and the possibility at this point, because of the high infectivity pressure and the rate of mutation of the SARS-CoV-2. I'm concerned about viral immune escape. And Tess, would you have knowledge about the possibility of viral immune escape with mass vaccinations, and how this can actually result in really bad mutant strains of the virus because it escapes our immune system?
I haven't done any research on this in particular, but I am watching the data very closely that are coming out. And all we can do at this point is follow the science and hope that that's not going to be the case. We are doing a systematic review on vaccine benefits and safety over the next couple of months, and this may be able to shed some light on what you're talking about. But at the moment, I don't actually have an opinion on it.
Okay, thank you.
Okay, thank you, Tess. Giorgio, can you take the floor? And then after that, Ernie Pernia. Yeah. Giorgio? Okay, it's not answering. So Ernie, can you take the floor now?
Yes, just a quick question to Tess Lawrie. Thank you, by the way, for your presentation. Somebody I think mentioned already how the ivermectin would fare, vis-a-vis the new variants of the COVID.
Because ivermectin has many mechanisms of action, it has a better chance against COVID than the new strains than anything else.
Yeah. Okay.
So we can wait and see. I can't say it will be great against all variants, but it certainly has a very broad spectrum, so it should be good against different variants.
All right. Okay. And then also I think my main takeaway from your presentation is that the safety rate of ivermectin is pretty high. Just safety. Besides the efficacy, or maybe the efficacy, in terms of efficacy, it is lower than the vaccines, because many vaccines are 90%, 99% efficacious. But I think ivermectin will be lower than 90%. But then the safety, I think, is more important. And the reason for that is if the safety is if the safety is reasonably high, then ivermectin should be considered a global public good. A global public good, because there are so many countries, poor countries, who cannot afford to buy the expensive vaccines, or who cannot wait so long to get the vaccines. In the meantime, as you said, so many people are dying. So what is the judgment there? I mean, it's very clear that it should be allowed. It should be it should be allowed as a prophylaxis or as a treatment. So that's what I'm saying. It's not just a public good, it's a global public good, given that there's so many poor countries, so many poor people in the world. Thank you.
Exactly. Who are disproportionately affected by COVID. And if you look at countries like India and certain states of India where they've employed ivermectin really early on, they have death rates comparable to that in the UK, which has 20 times lower populations. So, and in fact, it is, a very equitable intervention and can be very easily rolled out to people at an early stage, especially if they have to wait a long time for their vaccines. So,
Thank you, Tess. Yeah. Well, there are quite a number of people. Yeah, there are quite a number of people who want to speak. So let me just call them out, and we'll go take them in order. So Giorgio Castañeda, Jody Dalmacion, Silvia de la Paz, Hans Palacios, and Angelina Galang. So those are the people in my list. So could you make your comments and questions short? We can probably just accommodate these people, and then we'll have to call it a webinar. So can I call Giorgio Castañeda? Still not here. Okay, Jody Dalmacion then. Jody? Not there. Silvia de la Paz? Not there. Okay, Hans Palacios.
Hi, good evening. We had in Rotary Club of Manila yesterday, we were lucky to have the CDCPH, courtesy of Francis Abraham. And immediately after our 3.5-hour seminar, some of our members were blocked from social media because they started endorsing ivermectin. One of our members, Rafi Alunan, just posted a meme weeks ago of Juan Ponce Enrile endorsing it. So he's blocked for a month. Our president of the club is blocked for 3 days just for mentioning ivermectin. I don't even use the word anymore. My question is this. I'm really worried because all our services right now, the military, the police, the frontliners, the doctors, the barangay officials are all being vaccinated. We don't know, because these are untested vaccines. We don't know the side effects. So what if there is a bad side effect and all of a sudden in 3 months' time, they start bogging down? What will happen to our people? I mean, ivermectin, which is proven to be safe, wouldn't that be a good way? I mean, if we just give it to the police and the military just to hedge, would that be a good solution initially? I'm glad that NEDA Secretary Pernia is here, so he might be able to influence the president that this is something that is a serious matter for us right now.
Okay, thank you, Hans. Okay, does anyone want to answer that? Tess, do you want to address the point of Hans?
Well, I could just say that frontline workers certainly should be first in line for ivermectin if there's limited supply. And treatment, of course, obviously needs to be used for treatment, and also for frontline workers.
Okay, thank you. Let's go to Angelina Galang, and then Georgia after that.
Yes, thank you. Thank you. You mentioned, and it has been written, that in certain areas or parts of some countries, the success of ivermectin has been obvious. for example, in a state in India. But the rates of infection in India is also skyrocketing. Is it not being promoted there? Is the government resisting it? And I think the same it has been pointed out about Brazil. That is very accessible. It's over the counter, but it has a lot of cases, as we know. No, it has been reported.
Yes.
So, is it a lack of promotion? Is it ignorance, or is it resistance on the part of government? That's my question. Thank you.
Thanks very much. It's a good question, and I don't know the answer to that, why the rates are suddenly going up. We can only ask, we can only wait to see what.
Please mute David Dixon. Can you mute? Sorry.
We can only ask our experts who deal with that real world data to give us some explanations, which hopefully will be forthcoming in the next couple of weeks.
Dr. Bayani.
I can answer that.
Okay, do you want to say anything, Iggy?
Yeah, I can answer that.
Okay, very briefly lang.
If you look at Brazil, it's a very big country. Sao Paulo, for example, has no cases. And it's one of those places where they had a study of ivermectin. So you cannot just look at the data for the whole country. You have to look at the region. So the regions that use ivermectin well are doing good, and the regions that are not doing. But overall, it looks like it's bad. Same with India. Uttar Pradesh is the place that used it a lot, and they're doing quite well. But maybe not as because it wasn't used well in other areas of India. But overall, India is doing well compared to other regions with the same population size.
Peru.
Okay, thank you. Can we now move? Okay, I'm going through the list again. Giorgio Castañeda, are you there? No, it's probably gone. Silvia de la Paz. Okay, none. So I see another raised hand. Francis. Francis, have one.
Hi. Good. Hello. Can you hear me?
Yes.
Okay. Good evening, Dr. Lawrie. There are 4 other meta-analyses that have come out, and I believe you have read them. How would you compare the other meta-analyses that came out to yours?
Thanks for the question. Yeah, they all seem to use a selection of studies. So there's a meta-analysis by a Spanish group with the lead author Castañeda Sabogal Castañeda, and in that study they say they're doing a systematic review, but they only find 5 trials for the analysis of deaths. Which is surprising because we know that there's much more data. So that review we critiqued in our article and found it to be low quality using the AMSTAR tool. So and also you must bear in mind that these critiques are always done at least 2 people. So that review is much lower quality than ours, and the same with the Hill review, where there's no grading applied, and the conclusions don't match, and there's also that was quite early on, so the evidence base has evolved and there are more trials now. So ours is the most up-to-date meta-analysis, and then as I pointed out, the flaws in the McMaster's review, which is also a very restricted group of studies that fits with their network meta-analysis design. Let me think which one. There's an Italian group which just did a review of the literature, Nardelli, and they came to the same conclusions that ivermectin should be recommended, although they didn't do a meta-analysis, if I remember correctly. And then there's one other one by Cobos Campas, and they come to the same conclusion as with Nardelli, that ivermectin should be recommended and that it has probably a wide range of usefulness in COVID. So I hope that's
Thank you, Dr. Thank you, Dr. Lawrie. And lastly, I'd like to, as a membership head of CDCPH, I'd like to honor you as a honorary member of CDCPH. our concerned doctors and citizens of the Philippines. Thank you. Thank you.
Thank you very much.
Okay, thank you very much, Francis. So I think, we just have a few more minutes before we end. I think there's no more, there are no more raised hands, and those that raised their hand, I think left. So,
Manolete.
Yeah.
Yes, may I read out
Okay,
Fidel
please.
Caballero? Fidel Caballero's question. I'm a veterinarian. Can I share my experience practice on using ivermectin? Are you there,
Okay,
Fidel?
please.
Good evening. Good evening. We are the original supplier of ivermectin for animal health. So I was asking how you tolerate it, because how many years of using ivermectin for pigs, for ruminants? That means cow, carabao, kambing, and goat or sheep. I was surprised because for almost 30 years, practice in the veterinary industry, now they were using the ivermectin, or they were using it for human being. But as per FDA, it was licensed only for animal use for human being. So I just want to correlate it, because for how many years of practice in veterinary medicine and using ivermectin for internal and parasite, worms, or ticks or lice in animals. Now they were using it for COVID-19. And then, okay, as per FDA, the only product is with prescriptions. For animals, I've been using it for almost 30 years in deworming, in galis or scabies, especially for pigs and ruminants. How will you correlate it from animals to human being? Because since the patent for was expired in 1996.
Fidel, you're choppy. Fidel, you're choppy.
Okay. I will repeat. I've been using ivermectin and Ivermectin almost 30 years for warming and for skin problem. My question now, because topic being how will you tolerate it from animals to human?
Okay, I think the question of Fidel is that they've been using ivermectin for animals.
Yes.
Right. But and you're asking how it can be used for humans.
The FDA has described a doctor.
It's been used for humans already.
In the Philippines, it was only for topical, not for COVID-19.
Yeah, well, I think
for memo of FDA, it's for animal use only, but for human being, only topical for skin problem. As per FDA memo.
Yes. Well, actually, you're correct. FDA came out with a memo that said the products in the market were only for veterinary use. But I think that's actually the issue.
Yes.
That it be used for humans. And I think that's the reason they've given a compassionate special permit. And there are people who are arguing that it should extend beyond compassionate special permit. Okay, thank you, Fidel. Thank you.
Well,
I think we'll have to
read your
Yeah.
Okay,
we'll have to leave it there.
Manolete, before you do the synthesis, Manolet, and ways forward. There's just one comment here from Normel Panganiban to everyone. What we need now is reconciliation of conflicting thoughts, doubts, and knowledge in this matter. A consensus not only by experts, but by the entire, if not greater part of population. Different situation requires reinvention of approach to achieve immediate consensus that everyone, not only some or single entity, will be liable for the risk, but directed towards those who will agree to use this ivermectin. I don't know if Romel is an MD, is very concerned about this. So anyway, anyone wants to comment on this, like Dr. Jojo Mantaring?
I agree. But again, for everyone, especially the scientific community, to accept ivermectin, the easiest thing really to do is to wait for the results of the clinical trials. I think Dr. Tess Lawrie has said that there are still ongoing trials, and I believe the volume of ongoing trials is enough to suggest that it can really sway the results. Everyone wants a drug that works for COVID. I want a drug that works for COVID, but I'm not going to be comfortable about prescribing that drug if it's not substantiated by the evidence.
Thank you, Jojo. We would like to hear from Dr. June Belisario and Dr. Benjamin Ko if they're here, and then also from Dr. Tess Lawrie.
Shall I talk now?
Yes, please.
Okay. Well, I would like to urge you all to persuade or to motivate for ivermectin not to just be used for compassionate use, because that is leaving it too late, really, when the best effects will be seen early on and will actually prevent people from getting to the stage where you have to start thinking about employing things for compassionate use. And yeah, and as far as further trials go, I would say, yes, there are ongoing trials, but we certainly don't need to wait to start saving lives while we wait for those data. Thanks.
Thanks, Tess. What about Manolet, synthesizing at this point?
Yeah.
Because I'm sure that June and enter here.
Yeah. Can I just 1 minute?
Okay, Rafi.
1 minute. Yes, thank you, Manolet, Giselle. Because I think the last comment actually mirrors and it capsulizes everything that we're fighting for. Because every Filipino is a stakeholder in this crisis. And every Filipino has a right to be listened to voice out what they want. Our fate should not be decided on by a small committee or task force which can decide whether ivermectin can be made available or not. So again, they have to consider the people's sentiments because they're the ones dying, they're the ones suffering, and they're the ones filled with angst. So if we allow cigarette smoking, cigarettes, alcohol, and all these proven toxic agents to the body, why can't we allow something that can be potentially life-saving and not as harmful as all these products that we allow in the market? So again, very difficult to understand the dichotomy, the incongruence of our policies there. So I think everyone should be considered as a stakeholder, not only the experts, and they should be counted upon. They should be considered in our decision-making policies.
Thank you very much, Rafi. Thank you, Rafi. Okay, Giselle, do you have any comments before we wrap up?
Yeah, Manolet, before you wrap up, I think we'd like to ask Dr. Mantaring and Dr. Tess whether a local clinical trial is in order, because in that way, in the framework of a clinical trial, we would be providing ivermectin to sick patients of a certain category or a degree of severity. Is this something that should be done here? Dr. Jojo and Dr. Tess, please.
In my opinion, it will take a while before a clinical trial will be approved, will receive ethics approval, or will be completed. I think what's more prudent is just to wait for the ongoing trials. More and more trials are being completed even as we speak, and when the results come out, then that's when we can pass final judgment on the effectiveness of ivermectin. So I don't think there's a need to do a trial in the Philippines. That might be the waste of time.
I agree that we shouldn't conduct any more placebo-controlled trials, but I do think there's a place for trials, certainly for prevention. As I mentioned earlier, one could look at different dosing for prevention, fortnightly versus monthly. One could look at trials in long COVID, and one could also look at different dose regimen for treatment. For example, 3-day treatment versus a 5-day treatment. Those kinds of trials would be of interest. I certainly don't think we should wait, though, for clinical trials. There's plenty of data now. There's sufficient data. And in actual fact, ivermectin needs to be employed.
Okay.
4 billion already used it. And there are no bad side effects. The worst thing that can happen to us is we have no worms in our bodies or bacteria. Why don't we use it now? We don't have any vaccines anyway coming. Only 2 million have had it so far. There are 110 million Filipinos. The 108 million are waiting. And then we're going to go into lockdown until Christmas time before we hit 20%. So this country is just going to go bankrupt from all this dilly-dallying. That's what I'm saying. So the government should act up, and Pernia is here.
Okay, thank you, Hans. Okay.
I think Vic has something to say. Vic Ilag, you have last words?
Yeah, sure. Yeah, one thing. Yeah, it's Vic. I think for one, just to make sure for everybody, you do not require randomized clinical trials to approve a drug. And secondly, my concern, the ongoing trials, are they designed according to what will be satisfied by the Philippine authorities? Because I mean, those are trials which are ongoing. First, we're not sure the design, or we're going to be in the same spot 2 months later, and then decide, look at it, oh well, they're not of good quality. So that's it. I think pursue what we have, and I think wait for the vaccine. Yep.
Thank you, Vic. Okay, Giselle, anything else? Any other?
No, I think.
Any other reactors want to make a last word?
Excuse me, I just wanted to ask, how come they don't ask clinical trials that was done by the vaccine creators? How come all of these trials that are asking are from ivermectin? Why not all those vaccines? Have they really tried it? They don't know anything about it, actually. They don't even know if it's going to work. And if there's a side effect, and there are lots more dying from vaccine than from the ivermectin.
Thank you. Thank you.
Right?
Okay, Giselle? Okay. I think we have to close now. Giselle?
I think that this has been a very enlightening, enriching discussion. May I please ask others to mute, please? Yes. So, Manolet, as I had said, so PAASE is here to bring us all into a discussion that is rational and collegial, okay? And it's our way to contribute to moving forward on the issue of ivermectin. Okay. All right, and we in the PAASE have this role to play, to hear both sides. And we hope that those who are here present from government, academe, the medical doctors, and our experts, the pseudo experts. Of course, I don't think Dr. Belisario was referring to our other doctors as pseudo experts. I don't think that's what he meant. Okay, but anyway, then all the lay people who are interested in this topic of ivermectin, I hope that you come out of this fireside chat with more enlightenment on this burning issue. That is why it's a fireside chat. Okay, these are burning issues in our country, and you know, we cannot close our eyes on this. And so the best we can do at this point in PAASE is to bring you all together, and we hope that this is our way out with light in our minds and our hearts, okay, out of the pandemic. So, Manolet, you have the last words on this. Thank you, everyone,
Okay,
on behalf
maybe
of PAASE.
first of all, just to thank everyone. Thank you very much, Dr. Tess Lawrie, for this, this excellent opportunity to hear your voice and your analysis of the studies. Very, very enlightening. Thank you to the reactors. This was really meant to be a session where we would ask very, very pointed questions and really try to dig deep into the evidence. So thank you very much to Dr. Mantaring, Jojo, to Benji Ko for his comments on the pharmacology and the pharmacodynamics and pharmacokinetics, to June Belisario for his insights on ivermectin as an antiparasitic drug, to Rafi Castillo for his very, very passionate call for pragmatism, to Iggy Agbayani for his proposal that there be a drug, emergency drug use or drug emergency use proposal. And finally, to Vic Ilag, who reminds us that we have a virus that multiplies exponentially, and you have to counter it with drugs that need to dampen that exponential growth. I will end on just 3 points, okay? Just as a quick summary. We've actually discussed the quality of the evidence, okay? And Tess Lawrie has presented, her views on that, and so has Jojo Mantaring. We talked about bias, we talked about precision, we talked about consistency, we talked about the directness of the evidence, okay? And we talked about the quality of the evidence, high, moderate, and low, and how you might use, these different categories to make a decision. So that's the first point. We looked at the quality of the evidence. I think the second point is that we actually talked about the benefits versus the risks. And, that was actually emphasized a lot. And you make the judgment. What are the benefits for using this drug versus the risks of using this drug? Okay, and a lot was said about that. But the third point has to do with, and I think the reactors, particularly Rafi made this point towards the end. In the end, it's patient values and preferences. Okay, and I think the fact that there are so many people that are passionate about this already reflects patient values and preferences. And we can quantify that. We are actually trying to quantify that with the survey of the doctors, okay, with the survey of the doctors that tell us, what are their views about the use of ivermectin for prophylaxis as well as for treatment. So I'll leave it there. These are the 3 main things. We have takeaway messages for all of those points: the quality of the evidence, benefits versus risks, and patient values and preferences. We can mull over that. I think finding the way forward really has to do with the gatekeepers, with the regulatory authorities that eventually make the final judgments and the final go ahead on this. And I think there's a lot of them to chew on based on this almost 4-hour webinar that we've just had. So thank you all very much. And I would like to thank all of the participants. We almost reached 800, I think, in the course of this. We're down to still about 536. So a lot of interest on this. So thank you very much to all. Giselle?
Thank you so much. We reached almost 1,000, 990
Okay,
something.
1,000. Okay, thank you. And it's been a pleasure moderating this. Tess, thank you very much.
Very much, Tess.
It's been my pleasure and a great honor. Thank you.
Thank you,
Okay,
Jojo.
thank you. Thank you, everyone. Thank you, Tess. Thank you, everyone.
Bye.
Manolete,
Bye-bye.
Giselle, and everyone. Thank you.
Iggy, Dix, and June Bell. Thank you.
Bye. Thank you.
Thank you so
Bye.
much.
Okay, I'm signing off. Okay, Giselle, time for dinner.
Well, I had to munch on something.
Okay, thank you.
Thank you so
Yes.
much, Manolete. Okay, I hope,
Thank you, Giselle.
it's our last, no? I mean,
Okay.
yes, we've tried to do our
Excellent.
share, this ivermectin. All right, thank you. Thank you so
Bye.
much, everyone. Bye-bye. Good night.